Hi, this is Shivaraman from Johns Hopkins University. Now, over the course of this lecture, I'm going to talk a little bit about the most current concepts in the CT evaluation of acute pancreatitis. Now, we're going to begin with a very brief discussion of background, including the pathophysiology and some of the most common causes of acute pancreatitis. But we are going to concentrate most in this lecture on making the diagnosis of pancreatitis on a CT scan, identifying significant complications that I think you as a radiologist should be able to identify, utilizing the most recent classification schemes and nomenclature systems in your own dictations, and then finally, how you can use your dictation to really affect how the patient is treated and intervened upon. Now, as all of you know, acute pancreatitis is incredibly common. There are somewhere in the order of 300,000 cases per year in the United States, and it is certainly one of the most common causes of abdominal pain in the ER setting. Now, to make the diagnosis of acute pancreatitis, you really have to have two of three features: a good clinical history of abdominal pain, a markedly elevated amylase or lipase level, or a characteristic CT scan. Now, notice that I said two of the three, not all three. So it is possible, albeit not that common, to be able to make the diagnosis based on a clinical history and a characteristic CT scan, even if your amylase or lipase levels are normal or perhaps just minimally elevated. Now, if you look at any textbook, there are literally dozens of different causes of acute pancreatitis. But that being said, regardless of where you practice, whether it's Hopkins or elsewhere, the vast majority of cases, probably in the order of 90 to 95% of cases, are attributable to one of two causes: alcohol abuse or biliary stones. And the other causes you may or may not see in your practice depending on where exactly you practice. So drug reactions, ERCP, hypotension, hyperlipidemia, hereditary pancreatitis, the list goes on and will really depend exactly on where you practice. Now, it is worth noting that acute pancreatitis is, for the most part, very well tolerated. The vast majority of patients are in the hospital just a few days. They're going to be treated conservatively. They're made NPO. They don't have any major complications. And most people are going to go home after a couple of days without any major sequelae. But that being said, it is worth noting that there is a small segment of patients with acute pancreatitis, most of whom have acute necrotizing pancreatitis, who have far worse clinical outcomes. And we've all seen these patients, right? They spend weeks in the ICU, months in the hospital, multi-organ failure, major complications, and many of these patients actually end up passing away. But that being said, it is worth remembering that the vast majority of patients are actually going to do quite well. Now, all too often when I'm working with a resident or fellow, people ask me, well, this patient has an elevated lipase level. Why are we wasting our time with a CT scan? What's the point? This is fundamentally a clinical diagnosis. And as far as I'm concerned, that's not true. As far as I'm concerned, CT does have a major role to play, both in terms of diagnosis, but also in terms of risk stratification and guiding treatment. First of all, it is important to remember, in the vast majority of cases, at least in my practice, we make the diagnosis of pancreatitis on a CT scan, and subsequently it's confirmed biochemically using a lipase level by the ER staff. So I think in most cases we make the diagnosis because CT is, after all, the most important screening tool in patients with nonspecific abdominal pain. Secondly, even once you make the diagnosis of pancreatitis, it is critical to figure out what the underlying cause of that pancreatitis is, and CT can play an important role there. Is this a case of gallstone pancreatitis, or one of those unusual cases where there's an underlying tumor, or maybe even a rare case of autoimmune pancreatitis? Just as importantly, once you've made the diagnosis, it is important to risk stratify the patient. Is this someone who's likely to have a good outcome, has a pretty benign CT scan, and can probably go home in a couple of days? Or is this someone who has major complications, is probably going to have a poor outcome, and probably needs to go to the ICU? So risk stratification can be very important in terms of deciding how exactly to deal with the patient, especially when they first come into the ER. Of course, you have to have that CT on admission to make sure there's no major complications. And if there are complications, CT is critical to help guide intervention. As I mentioned, one of the reasons why I think CT is so important is risk stratification. It is really important when the patient first presents to figure out whether this is a patient who's likely to have a good outcome or a poor outcome. Now, traditionally, if you go back in the past, risk stratification of pancreatitis was done using biochemical and clinical markers. And this is the classic formula, right? Ranson's criteria, a number of different biochemical factors put into a formula that allow you to predict a patient's outcome. Now, I think today it is less and less common to see our internist colleagues utilize the Ranson's criteria, and instead, CT has really taken over as the primary risk stratification tool. Now, the original classification system or risk stratification system for pancreatitis on CT was the Balthazar system, first devised in the mid-80s and then revised again in the early 90s. Now, the Balthazar system really does something that should be intuitive to us, and that is that it makes a direct correlation between the severity of the patient's pancreatitis and their CT scan. So, in other words, the worse your CT scan looks, the worse the patient is likely to do. And that may seem intuitive, may seem simple, but it is actually a very fundamental key point in terms of the importance of CT. Now, the Balthazar system is pretty simple. A through E. A is a normal-looking pancreas, so you can have mild biochemical pancreatitis with a normal-looking CT scan, all the way up to a horrible-looking pancreas with lots of collections, retroperitoneal gas, and that's the Balthazar E. And of course, the degree of pancreatic necrosis is going to play a role here in terms of what the patient's grade is. Now, the Balthazar system has largely been supplanted by the revised Atlanta classification, which isn't fundamentally that different, right? It takes into account a number of different CT imaging features, the degree of necrosis, the presence of complications, spits out a formula that's going to help you predict whether the patient is likely to have a good or a bad outcome. Now, you don't need to memorize the revised Atlanta classification because, honestly, I don't know anyone who actually uses it in their dictation. But it is important to understand what kind of things it puts emphasis on, and specifically to understand its emphasis on the degree of pancreatic necrosis, a numerical emphasis. Notice that there's a great deal of importance in this system on the number 30%. So patients with more than 30% pancreatic necrosis are at especially higher risk of having a poor outcome. So it is important when you're looking at these CT scans and there is evidence of necrosis to judge whether it's greater than or less than 30%. Now, as I mentioned, I don't use the revised Atlanta classification. I use the Fishman grading system, which is honestly probably much more practical and what the clinician wants to hear. They really want to know, based on the CT scan, is this mild, moderate, bad, really bad? In other words, how well or how poorly is my patient likely to do? So it's not enough in your dictation to just say the patient has acute pancreatitis, period. That is not a useful dictation. What is useful is to say, well, this patient has horrible pancreatitis with a bunch of complications, they have this and this feature, this much necrosis, and allow the clinician to paint a picture so the clinician can get a sense for whether this patient is someone who needs to go to the ICU and needs to be watched very carefully, or alternatively, is this one of those run-of-the-mill cases of pancreatitis that can go to the floor and is likely to be out of the hospital in a couple of days. Now, how do we image these patients? Now, I'm a strong believer that anyone with suspected pancreatic pathology, and that includes pancreatitis or pancreatic masses, needs a dual-phase CT. So we're going to acquire arterial and venous phase images at roughly 30 to 35 and 60 to 70 seconds respectively. Now, we do not give these patients positive oral contrast, not only because it interferes with 3D post-processing, but also because it can create beam hardening and streak artifact, especially when pooled in the stomach, that might potentially obscure a subtle stone in the ampulla or even an underlying pancreatic mass. Instead, just give water. We give about 1 liter of water as a neutral agent. It distends the stomach, and it works perfectly well without creating all these other problems in terms of interpretation. Now, it goes without saying you really do need to give IV contrast. I hate looking at acute pancreatitis cases that are non-contrast. You're not going to be able to pick up necrosis, pseudoaneurysms, and a bunch of other complications. I really do think patients need an initial contrast study, and we give 120 cc's of non-ionic IV contrast at a brisk injection, typically about 3 to 5 cc's per second. Now, when you're talking about acute pancreatitis on a CT scan and making the diagnosis, I really do think you're better off looking at this as two separate, closely related diagnoses. One diagnosis is acute interstitial edematous pancreatitis, far more common, and relatively benign in terms of its clinical impact. And on the other hand, acute necrotizing pancreatitis, which is far less common and far more clinically severe and more likely to cause long-term issues. Now, interstitial edematous pancreatitis accounts for somewhere in the order of about 3/4 of all cases. These patients, by definition, have a normally enhancing pancreas, so there is no evidence of underlying necrosis. And so to make this diagnosis with confidence, you have to have an IV contrast scan, right? You can't tell whether or not the pancreas is enhancing normally if you don't give intravenous contrast. Now, it's important to remember, at the most mild end of the scale, you can have a normal-looking CT scan and have very mild edematous pancreatitis based on an elevated lipase. And this actually occurs more often than you think, probably in the order of about 25% of cases. But in most cases, you're going to see some findings suggesting edema. an enlarged, edematous-looking pancreas, loss of normal fatty lobulations, some peripancreatic fat stranding, inflammation, and free fluid. And typically that fluid will track along the anterior pararenal spaces, and you may even see some thickening of Gerota's fascia. Now here's a classic example of acute pancreatitis, right? You can see that the pancreas is enlarged, you're starting to lose some of those lobulations, and there's lots of peripancreatic free fluid and inflammation. Most importantly, you're going to track along and look at the entire pancreas, and you see that there's no areas of non-enhancement or severe hypoenhancement. So this is acute edematous interstitial pancreatitis. Here's another case. This is a patient who had a recent ERCP. Again, notice that the pancreas is big, it's edematous, it looks more packed in, there's loss of fatty lobulation, there's some peripancreatic edema and fluid. This is edematous pancreatitis. Note that the entire pancreas is enhancing normally. Now, it's not always the case that your pancreas is going to look big and edematous. There are cases, as in this instance, where the pancreas itself may look relatively normal in size, maintained fatty lobulations, but it's that subtle peripancreatic edema and stranding that gives away the diagnosis of edematous pancreatitis. Now, as I mentioned, edematous pancreatitis is very well tolerated. The vast majority of patients are not going to have any complications, and in most instances, as long as their initial staging CT scan did not show any complications, you do not need to routinely follow up these patients with another repeat CT, provided that their lipase trends down and they're clinically getting better. The only reason to do a follow-up scan in these patients is A, they had a complication that you need to follow up, like a fluid collection, or B, they're getting worse clinically and you're worried that they've developed pancreatic necrosis or some other complication. Now, I think it's important to remember that the pancreas is not the only organ in the anterior pararenal space. It shares that anatomic space with several other entities, including the duodenum, the ascending colon, and the descending colon. So it is theoretically possible, and in fact not that uncommon, that pancreatitis can be mimicked by other pathology, including duodenal ulcer disease, colitis, diverticulitis, so on and so forth. And these are obviously entities that are treated very differently, carry very different prognoses, and really it is important to make the clinical distinction. So here's an example. This is a patient who, just based on this image alone, I think all of us would probably consider the possibility that this is likely acute pancreatitis, right? There's fluid tracking along the right anterior pararenal space. There's fluid in the vicinity of what I think is the pancreatic head and duodenum, probably acute pancreatitis, right? Well, wrong. If you look more carefully, you look a couple of slices below and you use the coronal reformats, you realize that this fluid and edema is actually centered not around the pancreatic head, but rather is centered along the duodenal sweep. There's actually fluid and ectopic gas tracking from the duodenum. This is a perforated duodenal ulcer. And if you just kind of said this was acute pancreatitis without thinking a little hard, you potentially would have given this patient a completely incorrect treatment. Now, as I mentioned, there are two forms of pancreatitis. Necrotizing pancreatitis, the second form, is much less common, no more than about a quarter of all cases, but is certainly much more clinically severe and much more likely to cause major clinical morbidity and mortality. By definition, pancreatic necrosis implies that you have either diffuse or focal areas of either non-enhancement or severe hypoenhancement. So it goes without saying, really, to make this diagnosis, you have to have a contrast-enhanced study. As I mentioned earlier, there's nothing I hate more than reading a non-contrast study in a patient with known acute pancreatitis, because really you're not providing a lot of useful information. You're not going to be able to identify many complications, and you're certainly not going to be able to confidently identify pancreatic necrosis. As I mentioned earlier, the Atlanta classification, or revised Atlanta classification, puts a great deal of emphasis on the number 30%, right? Patients with more than 30% necrosis are at far higher risk of a poor outcome, so it is important in your dictation to give a numerical estimate. If you think there's necrosis, you want to say, is there 10, 30, 50, 70, 90? Now, you can't be entirely certain that that number is correct, but you want to at least give your best educated guess as to the percent of parenchymal necrosis, because that is going to directly impact how well or how poorly that patient is likely to do, and can really impact the clinician's decision on how exactly or how intensively the patient needs to be treated. Now, pancreatic necrosis results from thrombosis of the microvasculature feeding the pancreas. And that's because you have all these enzymes that are leaking out, these proteolytic enzymes that potentially are going to damage that microvasculature and cause thrombosis. So it's not surprising that that thrombosis or microthrombosis can take some time to develop. And accordingly, it is very common that you could have a normally enhancing pancreas at presentation, but subsequently develop pancreatic necrosis a couple of days later. So there is nothing wrong with re-imaging patients who have what looks like edematous pancreatitis at presentation, but are clinically worsening, are not getting better, their lipase is not trending down, and it's very important to re-image these patients because you may see evidence of pancreatic necrosis on the follow-up. Typically that follow-up, if you do it at about 2 days, 2 to 4 days, that's when you're most likely to identify evidence of developing necrosis. Now this is of course a clinically significant diagnosis. Vast majority of patients will develop at least single organ failure, many will develop multi-organ failure, and the mortality rate somewhere in the order of 12 to 30%, really depends on how severe the necrotizing pancreatitis is. Now the CT imaging features are distinct from what we talked about earlier in edematous pancreatitis. These patients have areas of either non-enhancement or severe hypoenhancement, and typically there's a lot of inflammation. You're going to see usually what looks like a massive phlegmon surrounding the pancreas. You may have trouble finding normal pancreatic parenchyma, and you're going to see this ill-defined hypodensity, fluid, and inflammation replacing where you'd normally find pancreatic parenchyma. Now in this case, you can see that there's a big phlegmon in the retroperitoneum. There are certain areas of the pancreas that look like they're enhancing normally, but frankly, I can't find much of the tail segment, can't find much of the head segment. So this is a patient who probably has 30 to 50% parenchymal necrosis. Here's another example that looks very similar. Big phlegmon in the retroperitoneum, very little residual pancreas, a little bit of head I can still see, a little bit of tail, but the entire mid portion of the gland is gone. Classic necrotizing pancreatitis. Again, I would guess probably in the 30 to 50% range. Now, even though in most cases you will see a big phlegmon replacing the pancreas, there are instances where the pancreatic shape may be preserved and you may see ill-defined areas of liquefaction within what is a normally shaped pancreatic gland. Here's an example where I think it would be pretty easy to say that this is just edematous pancreatitis, right? I don't see a big phlegmon, there's no big fluid collection, but if you look carefully, there are some areas of liquefaction. There is ill-defined hypodensity within the gland, so this patient does in fact have quite significant parenchymal necrosis. Now, I do want to make a distinction between two terms that people confuse all the time. There's pancreatic necrosis, which really means you have parenchymal necrosis or non-enhancement and carries with it the implication that you're at significant risk for morbidity and mortality. And then there's extrapancreatic necrosis, which is quite distinct. This implies nothing about the pancreatic parenchyma itself, but rather is a term used to describe the leakage of pancreatic enzymes into the peripancreatic fat with subsequent peripancreatic fat necrosis. Now, this does carry a slightly worse prognosis, but really doesn't have a major impact in terms of patient morbidity and mortality. So why do you worry about it? Well, the main reason is that extrapancreatic necrosis, like other forms of fat necrosis, can look very nodular, can look mass-like, and can be very confusing on a CT scan. I've seen many cases where this has actually been confused for carcinomatosis or tumor spread, and it can look very much like that. You can get nodularity, thickening of the paracolic gutters, base of the mesentery, and if you don't really, have you never seen this entity before, it's very easy to mistake it for something much more foreboding. So here's an example. This is a patient with acute pancreatitis. It was edematous pancreatitis. The pancreatic parenchyma itself was enhancing normally. And what about all this sheet-like tissue along the left anterior pararenal space extending downwards along the left paracolic gutter? Could be carcinomatosis if you told me the patient had pancreatic cancer, but they don't have pancreatic cancer. They just have pancreatitis. This is fat necrosis that went away on a follow-up scan. Here's another one. This patient, it was actually, this is a nice case that was sent to me by one of my ex-fellows who's now out in Oklahoma. And you can see that the pancreas is inflamed, edematous, enlarged. The patient had acute edematous pancreatitis. Unfortunately, it was a non-contrast scan. He was worried about this fullness in the pancreatic head, and what do you do about all this ill-defined induration and nodularity along the mesentery and the paracolic gutters? And so he asked me, do you think this potentially could be a pancreatic cancer with carcinomatosis? And I told him, yeah, it's possible. It's hard to exclude that without contrast, but I think this is most likely to represent extrapancreatic fat necrosis, and that's what it was. All of this resolved on follow-up. Now, once you've made the diagnosis of acute pancreatitis, and you've determined whether or not it's edematous pancreatitis or necrotizing pancreatitis, your job isn't done. You've just moved on to the second step. And the second step is to identify a number of common complications that I think are critical to be able to identify and that may have implications in terms of treatment. So let's start by talking about a couple of complications that are specific to patients with necrotizing pancreatitis, and that's infected necrosis and central gland necrosis. Then we'll move on and talk about fluid collections, and specifically the nomenclature suggested by the revised Atlantic classification, and how different types of fluid collections are treated very differently. And then finally, we'll talk about what I think is the most important complication, and that's vascular abnormalities, including venous thrombosis and arterial pseudoaneurysms. Now, when you have someone who has pancreatic necrosis, one of the complications you most worry about is infected necrosis. This is somewhere in the order of about a quarter to a third of patients with necrotizing pancreatitis, and it implies superinfection by bacteria of the necrotic pancreatic parenchyma. Now, these patients are at very, very high risk for a poor outcome. In fact, if you don't treat these patients appropriately, infected necrosis has a mortality of essentially 100%. Now, this usually occurs about 2 to 3 weeks after clinical onset, but I've seen it earlier, so the time course, as far as I'm concerned, doesn't help you that much in terms of formulating a diagnosis. Now, it is important to remember that these patients typically are not just treated with IV antibiotics or even putting in a surgical drain, but usually the presence of infected necrosis does imply that you need to go in, surgically debride the patient, and do a necrosectomy. Now, in many cases, you're not going to be able to make a specific diagnosis on a CT scan. You're going to see a big phlegmon, lots of inflammation, pancreatic necrosis, but in many cases, it's going to be difficult to make the distinction between sterile necrosis and infected necrosis. And in those cases where the CT scan is not definitive, you may need to actually aspirate or biopsy the pancreatic parenchyma or the pancreatic bed and see if anything grows out, especially if there's a strong clinical concern that the patient is infected. On the other hand, there is one imaging feature that allows you to make the diagnosis with virtual certainty, and that's the presence of extraluminal gas in the pancreatic bed. In a patient who's never been biopsied, never been intervened upon, never had a drainage catheter, extraluminal gas equals infected necrosis. You don't get ectopic gas in the pancreatic bed in patients with sterile necrosis. So if you see extraluminal gas, you're going to call it infected necrosis, and that patient does in fact usually need surgical debridement. So here's an example. This patient has necrotizing pancreatitis. You don't see much of the pancreatic head, neck, and body. There's actually hemorrhagic transformation. But this patient has never been biopsied, never intervened upon. There is ectopic gas in the pancreatic bed. This is infected necrosis. And the patient went on to get a necrosectomy. Here's an even worse case. Not much of the pancreas left. There's actually a big air fluid level where you'd expect the pancreas to be. Classic infected necrosis. And again, this is a patient who went on to the operating room to get debrided. Now, another complication you need to be thinking about specifically in patients with necrotizing pancreatitis is central gland necrosis. And this has a number of different names: mid-gland necrosis, disconnected duct syndrome, and so on and so forth. And there's a few other terms you'll hear out there. And these are really fancy terms to describe something that's pretty simple, right? It implies that you have necrosis of the central portion of the gland along with its pancreatic duct, while the body and the tail are spared. The head and the tail are spared. And what happens in these situations is because the central portion of the gland is necrotic along with its duct, you get continual leakage of pancreatic enzymes both from the head and the tail into the central portion of the pancreatic bed, and you develop a big fluid collection. And so in essence, this happens because the pancreatic duct in the central portion of the gland is disrupted, and you end up forming a fluid collection where the pancreatic enzymes collect. Now, this is an important diagnosis to make because that fluid collection is not going to be adequately treated by putting in a percutaneous drain. If you do put in a percutaneous drain, the collection is really never going to go away, and really you're going to be kind of stuck. Instead, patients who have real central gland necrosis need to be treated with either a distal pancreatectomy or an internal drain, typically a cyst gastrostomy. Now, in many cases, you're going to be able to imply the presence of central gland necrosis based on the CT, just based on the distribution of necrosis. So if I see the central gland completely gone, there's a fluid collection replacing it, but I still see what looks like an intact head and tail, I'm going to raise the possibility of central gland necrosis. And this is a diagnosis that in some cases you can make based on MRCP, but to be honest, ultimately, to prove the diagnosis, you need an ERCP. So here's an example of a case where I wasn't sure. There's a fluid collection replacing part of the pancreatic body, but I thought maybe there was still some pancreatic parenchyma remaining posteriorly, but I wasn't sure whether the duct was still intact or not because there was that big fluid collection replacing the central gland. So we recommended the patient be at least that the possibility of central gland necrosis be considered. It was proven at ERCP, and they ended up putting in a cyst gastrostomy. Here's another example. Again, you can see the tail is intact, the head is intact, but there's a big phlegmon replacing, or fluid collection replacing the central necrotic gland. This is central gland necrosis. So let's talk next about another category of complications, and that's fluid collections. Now, all too often, we tend to be pretty imprecise when describing pancreatitis-related fluid collections. Everything's a fluid collection, loculated collection, abscess. We use all these terms that really mean something very different to us than they do to our referring gastroenterology colleagues, especially our colleagues in surgery and gastroenterology who deal with a lot of acute pancreatitis. Different types of fluid collections in acute pancreatitis have different nomenclature or different names, and different types of collections carry very different implications in terms of how they're treated or intervened upon. Some collections can be followed conservatively, whereas others, you would argue, probably need to be drained. Now, in general, the nomenclature that you're going to be using, based on the revised Atlantic classification, will depend on whether you're dealing with a patient who has edematous pancreatitis or necrotizing pancreatitis, and the time course in which that fluid collection is developed. Now, in patients with edematous pancreatitis who develop a fluid collection in the first 4 weeks after clinical onset, the term you're going to be using is an acute peripancreatic fluid collection. And as that collection evolves over time, after 4 weeks, then you use the term pseudocyst. And remember, pseudocyst is a term we're all guilty of using way too often. You know, I read reports and people call everything a pseudocyst. But technically, a pseudocyst is a collection that's been around at least 4 weeks in a patient with edematous pancreatitis. On the other hand, in a patient with necrotizing pancreatitis, a collection in the first 4 weeks that's ill-defined and not yet completely loculated is a post-necrotic fluid collection. And as that collection evolves and becomes loculated after 4 weeks, then the term you're going to use is walled-off necrosis. Now, in edematous pancreatitis, collections in the first 4 weeks, we're going to use the term acute peripancreatic fluid collection. These are collections that are simple in appearance. Remember, they're going to be composed purely of pancreatic enzymes. They're not loculated. They don't have an appreciable wall. They conform to the shape of the retroperitoneum. And because there's no necrosis, you shouldn't be seeing any evidence of internal hemorrhage. You shouldn't see internal blood products or other necrotic debris. These collections almost always go away on their own, and you only need to treat them if there's evidence of infection, which there almost never is. So these should be conservatively treated. There's no reason to put a needle into one of these collections in an asymptomatic patient. Now, these collections typically go away on their own, but in those cases where they don't go away on their own, they evolve into loculated collections, which after 4 weeks are termed pancreatic pseudocysts. Now, these are now well-defined loculated collections that have a clearly defined wall composed of fibrosis or granulation tissue, and no longer just conform to the shape of the retroperitoneum, but actually exert mass effect. Now, even pseudocysts, for the most part, do not often create clinical problems. At least half of these will resolve spontaneously, and only about a quarter will actually cause symptoms, pain or infection. Now, pancreatic pseudocysts can occur anywhere, but of course they occur in the most common places where you'd expect, given where the pancreas is located. So the right and left anterior pararenal spaces, the lesser sac, but honestly, pseudocysts can go almost anywhere. I've seen them track into the spleen, track up into the mediastinum, intraperitoneal, retroperitoneal, soft tissues. If you can think of a location and some way in which they could conceivably get there, a pseudocyst can get there. So here's a nice chart that really nicely illustrates the evolution of an acute peripancreatic fluid collection into a pseudocyst. Notice that initially the collection in the upper left is conforming to the shape of the retroperitoneum. It's non-loculated, but over time it becomes loculated with a well-defined enhancing wall and starts exerting mass effect on the stomach. And you can see in the last image on the bottom right, they've put in a cystgastrostomy. Now, the most common location is in the lesser sac, and usually not a problem, but they can grow quite large and can cause symptoms as a result of mass effect on the adjacent stomach or duodenum. And as I mentioned, they can go almost anywhere. Here's an example of pseudocyst actually tracking into the spleen. So if you see a fluid collection, you're not sure what it is, the patient has a history of acute pancreatitis, at least think about the possibility of a pseudocyst. Now, as I mentioned, pseudocysts should generally be managed conservatively. There is no reason that you should be putting a drainage catheter or a needle into a pseudocyst in a patient who's completely asymptomatic. If these are asymptomatic, they are merely incidental findings that do not need to be dealt with. The only reason you drain these or put a needle into it is if you think it's infected or if it's causing symptoms because of mass effect. So it's causing bowel obstruction, biliary obstruction, or just patient pain. Now, in those cases where you do think potentially that you need to put a drainage catheter into it because of symptoms, be very careful about putting a catheter in, especially when the pseudocyst is adjacent to the pancreas, because many of these will still communicate with the pancreatic duct. And if you put a percutaneous drain into one of these collections that still communicates with the duct, that drain is never going to come out. So patients that still have a communication between a pseudocyst and the main pancreatic duct need to have internal drainage, either endoscopically or surgically placed. So this is a very complex slide talking about the algorithm for dealing with pseudocysts. I think it's much more simple than this. Bottom line, don't do anything about asymptomatic pseudocysts. Only deal with pseudocysts that are symptomatic. If they are symptomatic and they're in close proximity to the pancreas, do an ERCP first to make sure there's no communication between the pseudocyst and the duct. And if there is communication, they probably need to be drained internally. If there's no communication, then they can be drained percutaneously by a radiologist. Now, if you're going to do this internally, internal drainage, because there's communication, it can be done either surgically or endoscopically, but almost all cases nowadays are done endoscopically, at least at Hopkins. So here's an example of a pseudocyst in the lesser sac. It was causing patient symptoms of gastric outlet obstruction because of its location. We appropriately recommended the patient get an ERCP first. There was, in fact, a communication with the duct, so the patient ended up getting an internal cyst gastrostomy. Don't get yourselves in trouble by trying to put a percutaneous drain in a collection where you're not entirely certain whether it communicates with the duct or not. Now, the nomenclature we're going to use in acute necrotizing pancreatitis is different. In the acute setting, typically in the first 4 weeks, we're going to use the term post-necrotic fluid collection. Now, these collections look very different than the acute peripancreatic fluid collections that we talked about in edematous pancreatitis. These patients have necrosis, so these collections look very heterogeneous, inhomogeneous with solid necrotic debris, hemorrhage, blood products, fluid levels, all kinds of stuff. So they look very, very heterogeneous. Often these are associated with ductal disruption, and there is some debate as to how best to treat these collections. There are some institutions where post-necrotic fluid collections, because they offer a great environment for superinfection and this development of infected necrosis, there are some institutions where they would argue that all of these collections need to be drained preemptively to prevent subsequent infection. But that's not true everywhere. There are some institutions where these collections are just treated conservatively. Here's an example. This patient had necrotizing pancreatitis about a week ago. Big fluid collection replacing much of the pancreas. Because of the time course, notice that and because of the lack of loculation, you're going to use the term post-necrotic fluid collection. Here's another post-necrotic collection that's actually intraparenchymal within the pancreatic head. Notice that it's inhomogeneous, has some internal hemorrhage. This is a post-necrotic fluid collection. Now, this is one of the reasons why, an example like this, why some institutions will preemptively drain these collections, because you can go on to develop infected necrosis. Notice that this patient has a post-necrotic fluid collection replacing much of the body and tail segments, and there's now multiple foci of internal gas. And remember what I said earlier. Ectopic gas in the absence of intervention implies that you do, in fact, have infected necrosis. Now, if for whatever reason you don't intervene on these collections early, they will eventually evolve into a discrete loculated collection that you're then going to term walled-off necrosis. Now, these collections have been around at least 4 weeks. They are a mature collection that now has a well-defined wall, and for the most part can be sterile or infected, but if infected, there's a significant risk of higher morbidity and mortality, probably a mortality rate double. So you do want to look for the presence of gas within these collections. Now, walled-off necrosis can sometimes, if you don't know the patient's history, can be difficult to distinguish from a pseudocyst just based on a CT scan. Some cases of walled-off necrosis will look relatively homogeneous and low density and simple in appearance on CT. And this is one of those situations where MR can be quite helpful. It can really illustrate on T2 weighted images nicely the internal heterogeneity within these collections, including the necrotic debris that may not be readily apparent on a CT scan. And that can have some impact if you choose to drain walled-off necrosis, as usually walled-off necrosis, unlike a pseudocyst, will require a large bore catheter, internal drainage, or necrosectomy. Here's an example of walled-off necrosis. Notice the pancreatic head and neck are gone. There's a slightly inhomogeneous collection replacing the pancreatic parenchyma. This has been around for a while. Notice that it's got a well-defined wall. This is walled-off necrosis. Here's another example. This is a collection that's been around for a while. Notice the inhomogeneity, the internal debris, maybe even internal blood products. Classic walled-off necrosis. So here's a nice chart from radiology a few years ago illustrating or discussing the treatment options for different forms of fluid collections. I think the key thing from a radiology perspective is to really understand that different collections have different names, and those names matter. It's not good enough to just say that it's a collection or to say that it's an abscess or call everything a pseudocyst, because different types of collections do in fact have very different treatments. And if you use the wrong term, at the very least, it may make you look bad in front of your referring clinicians. At the very worst, it may lead the patient to get the wrong treatment. Now, don't use the term pancreatic abscess. This is a term that's not included in the revised Atlantic classification. It's imprecise. You can all see that, see how it could potentially apply to any of the previously mentioned terms we discussed previously. This is not a good term to use. I don't use it in my dictations ever. So let's talk next about our last type of complication, and that's vascular. And these are really the complications that I fear the most as a radiologist. You do not want to miss a vascular complication because the next thing you know, the patient could have bled out from a pseudoaneurysm, or they could have bowel ischemia because of a venous thrombosis. So you really have to take the time, look carefully at the major vasculature, and make sure that there's nothing that you're missing. Now, this is one of the reasons why I really do believe patients need dual phase studies to look at pancreatitis, because many of these vascular complications, especially on the arterial side, can be really tough to see on the venous phase. You know, I actually saw a case a couple of years ago where the patient ended up bleeding out, had a huge bleed, came in from an outside hospital, and you look at this outside CT, it was a venous phase study, and I couldn't see anything. I wasn't sure why the patient was bleeding. But then we repeated the scan internally, did an arterial phase, and there was about a centimeter and a half pseudoaneurysm. It's easier than you think to miss pseudoaneurysms if you don't have good dual phase studies. So try to get both arterial and venous phase images as part of your protocols. Now let's start by talking about venous thrombosis, which is probably more common. Very common as a result of intimal injury to the vessel from adjacent inflammatory change, but can also occur as a result of mass effect and compression of the vein by surrounding phlegmon or fluid collection. It's not surprising, given its anatomic position, that the splenic vein is the most commonly thrombosed vessel, but the SMV and the portal vein can be affected as well, albeit less commonly. Now, always be clued into the presence of possible thrombosis anytime you see varices. If you see varices that you can't explain, you need to go back and look and see whether there's either thrombosis or severe mass effect on the veins that's causing narrowing. Here's an example of an SMV thrombosis. These are easier than you'd think to miss on the axial images, largely because if you're going really fast and scrolling through the axials, very easy to overlook a short segment thrombus, but very easy to identify in a case like this when you look at the coronals. Here's another example. Again, even if you didn't see the thrombosis, the presence of these large gastropaploic and omental collaterals means that you've got to have something wrong with your central mesenteric vasculature. As I mentioned, most cases are thought to result from direct impact of those those enzymes on the intima of the vasculature, but these can also develop over the course of a few days if you have constant compression and mass effect on the vein by surrounding fluid collections or phlegmons. Here's a patient where on this image you can see that the SMV is narrowed by the surrounding fluid collection. On a follow-up a couple of days later, the SMV was thrombosed. Now, pseudoaneurysms are critical diagnoses not to miss, right? If you miss a pseudoaneurysm and it ruptures, the mortality rate is essentially 90%. So as I mentioned, arterial phase imaging is key. It is not good enough to just get venous phase images, especially when the patient first presents with pancreatitis. And I would argue follow-ups you might be better off getting, at least in the acute setting, you might be better off getting follow-ups with dual phase imaging as well. Now, these occur because the pancreatic enzymes leaking out into the interstitium weaken the arterial wall, and you get formation of pseudoaneurysms. As with the venous side, it's the splenic artery that's the most commonly affected, but any vessel can be involved, and the second and third most common vessels are the GDA and the pancreatic duodenal arcade. But any vessel can be involved, so it is important to look at everything. I always, on every pancreatitis case, create MIP reformats, usually in the coronal plane, from my arterial phase images, and I spend a couple of minutes looking carefully to see if there's any kind of a pseudoaneurysm that I've missed. Now, this is where you want to catch it, right? This patient has a subcentimeter pseudoaneurysm. There's a small amount of hematoma, so it's certainly on the verge of rupturing. This patient ended up going to angio, did fine, no problems. This is what you want to avoid. This is about a 2-centimeter pseudoaneurysm. It's ruptured. There's large hemoperitoneum, huge hematoma in the left anterior abdomen. This patient was hemodynamically unstable, ended up having a very rocky hospital course. Now, once you've identified complications and used your dictation to help guide treatment, your job still isn't done. Your last role as a radiologist is to look at those images and figure out, is there anything I can tell the clinician about why exactly this patient has pancreatitis? And the three entities you're going to be thinking about are gallstone pancreatitis, autoimmune pancreatitis, and an underlying malignancy. Now, as I mentioned, gallstones are one of the two most common causes of acute pancreatitis. And I will admit, gallstones are clearly not a strength of CT, but it is something that you can diagnose now and then. So if you see gallstones, that is something that you need to prominently talk about in your dictation, because gallstones are, after all, a very plausible explanation for why this patient would have pancreatitis. Now, much more difficult as a diagnosis is picking up those rare cases of autoimmune pancreatitis. Now, I've got to say, like during my training, I saw very few cases of this entity, maybe a couple. But now as an attending at Hopkins, and maybe it has to do with our patient mix here at Hopkins, but I've seen lots of these cases. I'd say that we see several of these every year, and we've saved several patients just in the course of the last 2 or 3 years that I know of that were thought to have either edematous pancreatitis or pancreatic cancer, and where we've been able to suggest autoimmune pancreatitis, and the patient really has been treated appropriately, whereas they might not have without the imaging. Now, this really is a form of chronic pancreatitis, not acute pancreatitis. And accordingly, these patients do not present with the typical symptoms of abdominal pain as you would in the acute edematous setting, but rather with symptoms that are more akin to malignancy. So often they'll have weight loss, diabetes. Now, these patients, if you're able to suggest the diagnosis prospectively, can be treated with steroids, and often they respond quite vigorously. So within the course of a few days, their CT scan can get dramatically better. Now, in those cases where you're not sure, autoimmune pancreatitis, in some cases at least, will be associated with an elevated IgG4 level, and if it is, it's a diagnosis that's relatively easy to confirm biochemically. Now, autoimmune pancreatitis tends to be diffuse in most cases. So in most cases, you're going to see a diffusely enlarged pancreas, albeit with an absence of peripancreatic stranding, edema, or fluid. So unlike edematous pancreatitis, where typically a really big pancreas is going to have lots of surrounding inflammation, here you're going to see a really big pancreas with a conspicuous absence of surrounding inflammation. Now, if you're lucky, you're going to see this low attenuation capsule or rim around the margins of the pancreas, and that capsule, or halo, as some people call it, will actually show delayed enhancement if you acquire multiphase imaging. Now, often these patients do have other signs of IgG4-related disease, and the most common of which is usually going to be IgG4-related cholangiopathy. So look for evidence of biliary dilatation, strictures of the distal CBD, and often the CBD will look thickened and abnormally hyperenhancing. Now, the pancreatic duct should typically be small or narrowed, and that narrowing of the pancreatic duct may be diffuse or segmental. Now, autoimmune pancreatitis is fundamentally an autoimmune process and is often related to other forms of autoimmune disease. So look for evidence of strange lesions in the kidneys, salivary gland enlargement, retroperitoneal fibrosis, unusual lung disease, mediastinal adenopathy, and so on and so forth. And all of those ancillary features may help you arrive at the correct diagnosis. Here's a classic example. Big pancreas, notice the conspicuous absence of surrounding edema and stranding. And to top it off, there's this subtle halo of hypodensity around the margins of the pancreas, classic edematous pancreatitis. Here's another example, big, boggy pancreas, and you'll hear the term sausage-like enlargement of the pancreas, which refers exactly to this morphology. Notice again that despite the size of the pancreas, the loss of fatty lobulation, I don't see much in the way of surrounding edema and stranding, so this probably isn't edematous pancreatitis. And to make the diagnosis, note that you see that there's this rim of, or halo around the margin of the pancreas. This is classic autoimmune pancreatitis confirmed with an elevated IgG4. Now, as I mentioned, there's often going to be evidence of other IgG4-related sclerosing disease. In this case, this is one of the more common manifestations that I've seen in my own practice, these unusual lesions in the kidneys. They can be mass-like, they can be wedge-shaped, usually hypodense, and people don't exactly know what these are, whether they're infarcts, ischemia, focal inflammatory masses. Regardless of the cause, it's actually not that uncommon. So anytime you see these other manifestations, at least consider whether your pancreatic findings don't necessarily reflect acute pancreatitis or conventional pancreatitis, but rather autoimmune pancreatitis. Finally, let's talk a little bit about pancreatitis versus malignancy. And this is an easier distinction in theory than it is in practice, right? I think all of us are worried about missing pancreatic cancers, right? It's horrible prognosis. You have a pretty small window in many cases to actually catch the tumor when it's resectable and when the patient can still be treated. And you certainly don't want to call something acute pancreatitis when there's an underlying malignancy, and then they come back and they've got metastatic disease and they're no longer treatable. So you do always want to consider the possibility of an underlying malignancy, especially given that pancreatic cancer can actually cause pancreatitis and present with pancreatitis somewhere in the order of about 3 to 5% of all cases. Now, in many cases, it can be tough. Pancreatitis can be focal or mass-like and can look a lot like a cancer, and if you're not certain, you may just need to get a follow-up, maybe in a week or a few days after the inflammation is resolved, just to make sure that there's not an underlying mass. But that being said, I do think that there are some features that should at least that should start setting alarm bells in your mind that you might be dealing with an underlying mass. First of all, remember that a dilated pancreatic duct, especially an obstructed pancreatic duct or obstructed CBD, is pretty rare in acute pancreatitis. Yeah, you could see it in patients who have chronic pancreatitis, I guess, but realistically, if you see an obstructed duct, you're probably not just dealing with acute run-of-the-mill edematous pancreatitis, you're dealing with something more, and you really need to work that patient up further for an underlying occult lesion. Secondly, acute pancreatitis tends to infiltrate anteriorly into the mesentery, right? You're going to see stranding and edema go anteriorly out into the leaves of the mesentery, outwards into the pararenal spaces. That is very different than pancreatic cancer, which infiltrates posteriorly into the retroperitoneum. So if I see posterior infiltration, I'm going to worry about a tumor, and again, I'm going to work the patient up further. So here's a good example. This patient has pancreatitis, no doubt. The pancreas is enlarged, it's edematous, there's surrounding stranding and edema. But notice that the common duct is obstructed, there's a pancreatic duct stent, and if you look carefully, there's actually an obstructing mass at the level of the pancreatic head. So always at least consider the possibility there could be an underlying mass. So in summary, I really believe that it is critical when you're approaching a patient with acute pancreatitis on a CT scan that you take an algorithmic approach. There's a lot to look at, there's a lot to think about, there's a lot of different possible complications that you need to be on the lookout for. And if you don't have that algorithmic, reproducible approach, it's really easy to let things go that end up being clinically significant. As far as I'm concerned, when you're looking at these scans, your first goal is to make the diagnosis. Do they have pancreatitis or not? And then to figure out whether or not they have edematous pancreatitis or necrotizing pancreatitis. Once you've made the diagnosis, you want to then figure out what the severity of the process is. Is this a patient who's likely to have a good outcome, or on the other hand, a poor outcome that requires more intensive care in the hospital? You want to figure out, are there complications? Is there evidence of necrosis? Are there fluid collections? Are there major vascular complications that need to be treated urgently? And beyond that, you want to put together a dictation that really is going to help your clinicians in terms of guiding treatment. Use the right terminology, use the terminology recommended by the revised Atlanta classification, because the terms that you use in your dictation have very significant and specific implications as to how the patient should be treated. So that's all for now. Thanks again, and I'll see you guys later.
Hi, this is Dr. Karen Horton from Johns Hopkins. I'll be speaking to you about CT of cystic pancreatic masses. Due to the widespread use of CT and MRI, this has really facilitated the discovery of pancreatic cysts. Often, this will occur in asymptomatic patients, so we're finding incidental pancreatic cysts, and we're going to discuss that. And this certainly presents a challenge for both the radiologists and clinicians, and a challenge for the patients as far as how do they manage this and if it needs to be treated or not. So what is the frequency of pancreatic cysts? Well, it depends on what part of the literature you're looking at. So if you look at CT, those studies where they look at CT scans and see how often they find an incidental pancreatic cyst, it happens between 1% and 3%. Now, MR is going to be much more sensitive. So those studies, it could be between 14 and 20% of patients will have incidental pancreatic cysts. Now, often these are just a couple millimeters. And so but we still have to decide what we're going to do with those. About 10% of people over the age of 70 are now diagnosed with pancreatic cysts, so they're definitely more common as people age. And so as a busy radiologist, you're going to see this in your practice every day. So you're going to have to be comfortable diagnosing them and giving a differential and recommending follow-up. It used to be thought that pseudocysts were the most common incidentally detected pancreatic cysts, but this is in the old days. And now what we see as the most common incidentally detected pancreatic cyst is actually pancreatic cystic neoplasm. So things like serous cystadenomas, mucinous cystic neoplasms, and IPMN. And that accounts for most of the cysts that we find incidentally. Now, it's important as we go on the discussion to keep in mind that most incidentally detected pancreatic cysts are actually benign or, at worst, low-grade indolent tumors that may not require aggressive treatment. However, some incidentally detected cysts that you're going to see, especially the mucinous variety, so mucinous cystic neoplasms or even IPMNs, will have malignant potential, so we need to address that possibility. So do you resect or do you observe? It depends on the literature that you're looking at, and also it depends on the size of the cyst. So just to keep in mind that some people use 2.5 centimeters as the threshold. And so if it's less than that, they would suggest that you observe. If it's bigger than that, you may consider resecting. Other literature say basically 3 centimeters is the cutoff. So a significant percentage of lesions smaller than 3 centimeters can be followed. But some of those will actually still be mucinous and would have malignant potential. But since actual invasive cancer is uncommon in lesions less than 3 centimeters, even if you had a 2 centimeter mucinous cystic tumor, it may be okay to follow those until they reach the threshold of 3 centimeters, if they do. Other studies suggest that all mucinous tumors are premalignant and need to be treated aggressively. So it really depends on where you are and how comfortable your surgeons are at following things that could be potentially malignant. But size isn't all that matters, right? The patient matters as well. The age of the patient, are they symptomatic? All those things are going to be important if you consider resecting. And then are there any features about the cyst besides size that can help you decide whether or not you should resect regardless of the size? If there are mural nodules, and we'll discuss this, that's a worrisome feature, so you want to be more aggressive in your treatment of those. Do you have ductal dilatation? Okay, especially when the pancreatic duct gets very large, then you're starting to think of a main duct IPMN, and those definitely have a higher chance of having a malignancy. Is there enhancement of the wall of the duct or the wall of the cyst? Is there adenopathy? And let's not forget, is this truly incidental or is the patient symptomatic? If the patient's symptomatic, you might have a small lesion, but you may want to consider resecting it based on the symptoms. So that all goes into play. If you look at meta-analysis, where do they happen? So cysts greater than 2 centimeters in the head of the pancreas are ones that typically they would go to surgery. And when you look at the meta-analysis, they compared a whole group of people with cysts over 2 centimeters, and they said what was the best treatment. So they compared Whipple surgery, that's pancreatic duodenectomy, yearly non-invasive radiographic surveillance, compared to surveillance with EUS, or compared to patients they do nothing. So in this meta-analysis, they looked at those 4 different pathways, what happened to the patients. Well, the survival was maximized if all the cysts were resected, regardless of size. So if you're simply looking at years of survival, then it makes sense to be more aggressive. But if you look at quality of life adjusted survival, so that's probably the most important to everybody, the do-nothing approach, I mean, don't even follow them, just ignore them, had the best quality of life in patients under 75 who had a cyst less than 3 centimeters. So that's what we were discussing. Smaller cysts, you might not have to be so aggressive. Over 85 years old, non-invasive surveillance is the best. And initial surgery didn't maximize the quality of life in any age group of cyst size. So you want to kind of step back when you find these at first and not rush off to surgery. You really have to think, how old is the patient? What's their life expectancy anyway? Do you really want to do a Whipple surgery on a 95-year-old with a 3 centimeter lesion? So those are all important things to consider. The other thing I want to mention before we get into the specific cystic lesions is, what do you do about really small cysts? So if you have a cyst less than a centimeter, it's really tough to characterize those by imaging, meaning CT or even MR. EUS does a better job because obviously the ultrasound probe is right along the cyst. But using CT or MR, you have to be a little careful trying to characterize things that are so tiny that you're not getting an accurate Hounsfield unit measurement and you're not being able to see inside the cyst. Recommendation for follow-up, again, cannot be based on imaging alone. The patient's symptoms are important. So if a patient presents with weight loss or jaundice, diabetes, or anorexia, and you have small cysts, you want to be a little bit more aggressive in trying to characterize these cysts. You may want to go to a EUS in these patients to really see what's happening on the inside of the cyst. Okay, so how are we going to characterize those? We're going to look for septations or loculations. We're going to say, are there calcifications? And if there are, where are the calcifications? And those are important. Where is the mass itself? Sure, any mass can occur anywhere, but certain pathologies tend to occur in certain parts of the gland. Is the main duct involved? That's important to know. As we mentioned before, are there mural nodules? Is there enhancement? Is there ductal enlargement? Is it unilocular? Things that tend to be unilocular are small IPMNs, lymphoepithelial cysts, pseudocysts. Microcystic, they tend to be serous cystadenomas. Macrocystic, those tend to be your mucinocystic tumors or your IPMN. And then once you get cysts with solid components, those are going to be your mucinocystic tumors. They could be your IPMNs with associated cancer, or they could be your SPEN. Those are your solid and papillary epithelial neoplasms. EUS is actually very good to characterize, and the reason why EUS is maybe a little better sometimes, especially in the small cysts, is they can aspirate them and they can look at the fluid. They can look at the CEA levels, amylase levels, those kind of things. Overlap does occur, but you'll be right most of the time as you start to characterize these if you have a system, and that's what I'm going to go over with you. Here's an article that discusses results of EUS and felt that these patients had CT, MR, EUS, and surgery, and that EUS with or without FNA was superior to CT and MR to accurately classify a cyst as malignant. So the fact that you can really get up close and see the internal architecture of the cyst as well as aspirate the fluid is critical. And I'm not going to go into the cyst analysis because it's really not part of radiology, but there are a lot of articles, and this one's from a couple of years ago, that really started all the excitement, thinking that if you get the cyst fluid, then you can look for mutations in the DNA that you see in the cyst. And then based on that, you can kind of predict what are going to be malignant and what isn't. Okay, but let's really concentrate on what we can do as radiologists. So that's classifying these lesions. Okay, and we're going to talk about all the cystic tumors. We're going to talk about cystic neoplasms, like serous cystic neoplasms, the mucinocystic neoplasms, IPMN, lymphoepithelial cysts, SPEN tumors, cystic endocrine neoplasms, and then sometimes ductal adenocarcinoma can have cystic change. It's really necrotic, not cystic, but sometimes they could look the same, so we'll discuss those. So we're going to characterize our lesions as serous, mucinous, or other, and that's what you should be doing when you're looking at a CT. Serous cystic neoplasms, the first one we're going to talk about. There you can see a pathology specimen. It has a very characteristic appearance at pathology and even on CT because it tends to be microcystic. So it's made of a lot of little cysts, and you can see that internal septations and that central scar, and that's very, very characteristic. So serous cystic neoplasms, also referred to as serous cystadenomas or serous cystadenocarcinomas. The carcinoma part is very, very uncommon. So serous cystic neoplasms comprise 16% of resected pancreatic cystic neoplasms. Most occur in women, so that's important to know, and women in the 7th decade. So these tend to occur in older women. They can occur anywhere along the pancreas. And at pathology and even on imaging, you can say, are they microcystic or macrocystic? So classically, they're microcystic, lots of little cysts. But sometimes they can look like big cysts, so they're macrocystic. And sometimes they can be unilocular, and those are the ones that are going to be tough for us. Because if it's a simple unilocular cyst, we're not often thinking of serous cystadenoma. So sometimes they get resected thinking they're mucinocystic neoplasms. But there definitely is a variation in the pathology of these lesions, but you need to recognize what the classic appearance is. Almost all serous cystic neoplasms are benign cystadenomas. Like I mentioned, the cystadenocarcinomas are extremely rare. Okay? What the cystic neoplasms usually look like is honeycomb or sponge-like appearance, like I showed you in that pathology specimen. Calcification, that's a good differential for these patients with these lesions. You will see calcifications, it's typically central, not along the periphery. So if you see that scarring towards the center and you see a calcification in the center, that's a good indication it could be a serous cystic neoplasm. Lobulations are frequent. It usually will not obstruct the duct. Now, any mass that gets large enough can obstruct the duct because of mass effect, but usually, especially the smaller lesions, won't obstruct the duct. So you won't see ductal dilatation, and that's a differential that you can use between a serous cystic neoplasm and an IPMN. And also it's important to remember that patients with von Hippel-Lindau get serous cystic neoplasms. Okay, so let's look at some cases. So here's an example. This is a man. Now remember, most of them are in women, but 61-year-old man who is asymptomatic, who has a cystic lesion discovered incidentally when we were imaging him for something else. And there's a perfect CT example of a serous cystadenoma. Okay, multilocular, central kind of scar, and a little dot of calcification in the center. So this is 4.4 centimeters. It was in the head. Again, the central scar, starburst calcification, classic for a serous cystadenoma. Doesn't necessarily have to be resected, but if the patient's symptomatic, or if it gets any larger, they're going to resect it, just because these can grow very large. And it's much easier to do a Whipple surgery, even if you know it's a benign lesion, when it's 4 centimeters, than trying to deal with this when it's 15 centimeters. Okay, again, you see multilocular tumor with central calcification. Okay, this is that honeycomb appearance. Typical serous cystadenoma. Okay, here's another patient. This is a 61-year-old female. This is a mass in the tail of the pancreas. Again, I think this is much bigger than the other one. You can appreciate that it's made up of multiple lobules and little punctate calcifications, maybe not in the complete epicenter of the cystic lesion, but centrally you have a dot of calcification. This was 11 centimeters, fine septations and calcifications. Here's another patient, again, multilocular, cystic, right? Multiple little cysts, septations, very good CT appearance of microcystic serous cystadenoma. This one I could see is maybe a little tougher, right? It's incidental mass, so what other differential do we need to look at? Okay, there's no pancreatic duct obstruction, right? So it's unlikely going to be an adenocarcinoma. So now you're in, is this a mucinous cystic neoplasm, an IPMN, or a serous cystadenoma? I don't like it for IPMN because you don't see communication with the duct, right? So then you would go, it's either a mucinous cystic neoplasm or serous cystic tumor. And sometimes you can't tell and you're going to have it resected, but this one I think there's enough of small little locules that would make you favor a serous cystadenoma. This one I think is a little bit harder. So this is a mass in the tail of the pancreas. It's cystic. There's peripheral enhancement and maybe a little dot of peripheral calcification, but it's oligocystic. And so then you're kind of stuck. So if you showed me this case, there's no ductal dilatation, I would say I would favor that this is going to be a mucinous cystic neoplasm. And that's what we thought going into surgery, but it came back as an oligocystic serous cystadenoma. So not a lot of locules, right? It's either a unilocular or an oligocystic serous cystadenoma, but that's fine, okay? So it's much better than the alternative. If the patient had a mucinous cystic neoplasm, that's a little bit more aggressive tumor. So sometimes you're not going to be able to tell the difference. So then you would go and be the most conservative and say this could be a mucinous cystic tumor or an oligocystic serous cystadenoma, and assuming the patient is healthy and can undergo surgery, these patients you would want to resect. Okay, so we discussed the serous part. Now we need to discuss mucinous cystic tumors. So this gets a little bit more complicated because you have the parenchymal mucinous cystic tumors and the intraductal. So the parenchymal mucinous neoplasms are mucinous cystic tumors or mucinous cystic neoplasms. The intraductal are basically the IPMNs. They could be main duct, side branch, or a combination of the two. Okay, here's a pathology example. And you can see it looks very different than the serous cystadenomas. These tend to be larger cysts. They can be multilocular or unilocular, but they tend to be bigger, the size of the cyst, and more soft tissue component. So mucinous cystic neoplasm, so this is the parenchymal variety, can be benign or malignant, and they're graded at pathology depending on how much dysplasia they have or the presence of frank carcinoma. They represent 25% of all resected pancreatic cystic neoplasms, again more common in women, much more common in women, and more commonly in elderly women in the 5th or 7th decade, and more common in the distal pancreas. So you can see 95% are going to be in the pancreatic tail, right? So if you have one in the head, it still could be a mucinous cystic tumor, but that would be uncommon, especially in a man. It does not communicate with the pancreatic duct, so that helps you differentiate them between a mucinous cystic neoplasm and an IPMN. And they often have recognizable septations. Okay, typically they're oligocystic, so that's different than your serous tumors, and eccentric calcifications, and that again is different from your serous tumors. And then you're going to be looking very carefully. Mural nodularity, thickening, larger sizes of these tumors are more worrisome, increase the likelihood of malignancy. If you know it's an MCN, okay, so if they do endoscopic ultrasound and the lesion only measures 1.5 centimeters, then you have a problem. Some of the literature would say you should just go ahead and resect, and others, like I said, say would still be okay to follow it until it gets larger. Okay, and I think it all depends what you're going to do with your patient and what's the acceptable surgical risk. So your decision in a 40-year-old may be very different than your decision in a 95-year-old. Your decision for doing a Whipple would be different than your decision to do maybe a distal pancreatectomy or even laparoscopic surgery, which is a lot less aggressive. So let's look at some cases. So this is a 43-year-old female. It's a lesion in the tail, so that's where it should be. It looks unilocular, or maybe a little septation that I see here, and then a little bit of calcification, right? But nothing that looks at all like the serous cystic tumors, unless it's an oligoserous cystic tumor. Okay, this one was 3.5 centimeters. So based on size and everything, and it has suspicious features because it has that eccentric calcification and septations. Okay, now this one is another mucinous cystic neoplasm. Same thing, in the tail, eccentric calcification and a little septation. Surgical resection was performed and demonstrated mucinous cystic neoplasm without dysplasia. Here's another patient, looks very similar. It's a tail lesion in a female. And what you see, it's 3.6 centimeters, so size-wise, we're already going to be a little bit concerned. No septations, no calcifications. 3D mapping shows it again and shows a little bit of soft tissue thickening where you see the arrow there posteriorly, so that's a little bit of a worrisome feature. We're worried about it anyway because it doesn't look like a classic serous cyst adenoma. It's not involving the duct. We're not thinking it's an IPMN, so you're kind of stuck. You're in that category of it being a mucinous neoplasm, and that's what it was at pathology, and this one had mild dysplasia. 62-year-old female, incidental lesion, pancreatic tail. Again, it's following the rule. This is 3 centimeter. It had minimal mural thickening and a little tiny focus of calcification. Looks like the other two. We're not going to call this a serous cystadenoma. We're not going to call it an IPMN. It's not communicating with the duct. So then we're in the category of mucinous cystic neoplasm based on the size and the patient's age. Surgery was performed, and again, it came back as a 4 centimeter mucinous cystic neoplasm with low-grade dysplasia. Could you have followed this? You could have, but at some point you're worried that that low-grade dysplasia will turn into invasive cancer. And so that's the decision that you have to make, and you have a 62-year-old healthy female, it's probably worth the surgical risk to do the distal pancreatectomy. Okay, so we discussed the parenchymal mucinous neoplasms, which is basically mucinous cystic neoplasms. Now we need to discuss the intraductal. Okay, so we have the main duct, the side branch, and then the combined. So this is what they look like, especially the main duct one will look like when they do endoscopy. You see the mucin in the ducts, in the dilated ducts. Okay, so IPMNs are the most common intraductal neoplasm. Like the mucinous cystic neoplasms that we reviewed, they're graded pathologically based on the degree of dysplasia and whether or not there's any high-grade dysplasia or invasive cancer. These are the ones that we're diagnosing incidentally all the time, so definitely increasing incidence of these because we're seeing them more often. And often we see them when the patient is asymptomatic. Okay, but if the patient is symptomatic, then most commonly they're going to present with abdominal pain or weight loss. These are more frequent in men and more frequent in the head of the pancreas. So you can see this is very different from our mucinous cystic neoplasms, the parenchymal variety. Unlike the mucinous cystic neoplasms, the IPMN are associated with ductal dilatation, and the ductal dilatation could be the main duct or the side branches. And visualization of communication with the duct is really the key to the diagnosis and distinguishing these from the other cystic tumors. The intraductal papillary mucinous neoplasms can be multiple or can be diffuse or can be a single cyst. The treatment, again, is guided by the surgical risk and any associated features there might be. Is the main duct involved? That's a bad sign. Is there mural nodularity? Is there ductal dilatation greater than 1 centimeter? What's the size of the cyst itself? All those things will increase the chance that there's malignancy in the cyst. Main duct IPMNs have invasive cancer in 45%, and they have high-grade dysplasia in 20%. That's why if it's involving the main duct, you're going to be more aggressive. Side branch IPMNs with invasive cancer is much lower but still present, probably maybe 10 to 15% in some cases, depending on the size. So let me show you a couple of examples. So this is an intraductal papillary mucinous neoplasm. This is a main duct. 79-year-old man with prostate cancer, so we're following that up. You can see that's a huge duct. It measures like 1.5 centimeters, and you can see the little dilated side branches around the edge of the tumor. Okay, that's a classic CT appearance of a main duct IPMN. Okay, so you might say, why can't that be an adenocarcinoma with an obstructed duct? Because when you have an adenocarcinoma that obstructs the duct, you'll get atrophy of the pancreas, right? This is not an atrophic pancreas. The pancreas size itself is fine, just the duct is huge and the branches are also dilated. Okay, here's another classic main duct IPMN. The main duct is expanded. This one's, again, about 1.5 centimeters. You can follow it throughout its course. High chance of there being a cancer in these patients. Remember, up to 40% in some studies. And then you have to decide what you're going to resect, right? Because in this case, they did a total pancreatectomy. Because if the entire duct is involved, you can't take out part of the duct and leave the rest of the duct, because you're not going to be able to predict where the cancer will occur. Here's another patient. This one, very dilated duct, and this is an atrophic tail. Okay, so this one you're going to have to decide, is this a main duct IPMN or is this adenocarcinoma of the pancreas? And most of the IPMNs that you're going to see are going to be smaller and not necessarily main duct. So this is an example of the classic appearance. Remember, they're more common in the head. 3.4 centimeter multiseptated cystic lesion in the pancreatic head. So you say, well, why isn't that a serous cystadenoma? It's not a great appearance for that. It could be, though. But when you have a serous cystadenoma, they're more common in women, right? But also, they shouldn't obstruct the duct, or involve the duct, I should say. So you can see in this case, there is enlargement of the ductal system. So that would be typical of an IPMN. So in this case, they did a Whipple surgery and pathology, had a side branch IPMN with high-grade dysplasia. So that's one definitely that you want to be resecting. Here's another patient, 86-year-old asymptomatic man, discovered incidentally. Okay, here we have coronal MPR and volume rendered images, and you see it's pretty big. It's a 5 centimeter cystic lesion in the pancreatic tail. You can see that the duct is prominent. So already we're thinking, could this be an IPMN? And so they do a distal pancreatectomy, and it was IPMN with moderate dysplasia. This is the typical cases we see. In this case, there's a small lesion. Well, I guess not so small. When you do the 3D imaging, it was measuring up to 3.5 centimeters. It was a tubular lesion in the head or uncinate process. That's the most common place that you're going to see it. There it is. You can see it. And that arrowhead is showing you the dilated duct. So it's communicating with the duct. So now you're thinking it has to be an IPMN, not one of the other cystic tumors. Whipple surgery was performed based on the size and the presence of mural nodules on EUS. So we didn't see them on CT, but based on size, the patient went to surgery, and this was an IPMN with low-grade dysplasia without an invasive component, so that was good for the patient. Here's another one, and you can see that there's a cyst there kind of in the proximal pancreas, and you can definitely see that that's communicating with the duct. So you have a dilated duct in kind of the distal body and tail, and you can see it leading right into the cyst. Okay, that's a good example of IPMN. Here's another one. You can see a little cystic tumor, and you can see just a tiny duct. Now, sometimes MR is a little better showing the communication with those small side branches because it's more fluid sensitive. Okay, so we talked about the serous tumors, and we talked about the mucinous tumors, and now we have the category of others. So what's in the others that can look cystic? There's lymphoepithelial cysts, SPEN, cystic pancreatic endocrine neoplasms, and then the cystic or necrotic adenocarcinomas. So lymphoepithelial cysts, very interesting cysts. First described 1985. So obviously they didn't start happening in 1985. They were classified as something else before that. But in 1985 they characterized them as a separate cystic lesion. They're relatively rare lesions. The etiology is uncertain. They can be multilocular, bilocular, or unilocular. They can range in size from 2 to 13 centimeters. They can be very large or small incidentally detected cysts. As I mentioned, the etiology is unknown. There's different hypotheses. One of the things they show in pathology is they have squamous cells. So they think it may be squamous metaplasia of the pancreatic ducts that then undergoes cystic transformation. Some people argue it could be ectopic pancreatic tissue within lymph nodes. Could be epithelial remnants within the peripancreatic lymph nodes. Or it could be ectopic remnants of these brachial cleft cysts that are misplaced or fuse abnormally with the pancreas or near the pancreas during embryology. So what is specific about them? Well, the pathology is pretty straightforward because these cysts are lined by squamous epithelium. Okay, very unlike the pathology of the other cystic lesions. And there's lymphoid tissue with germinal centers surrounding the epithelial lining. So that's why there's that theory of them starting in a lymph node. Okay? They contain a lot of debris and these cholesterol clefts. So apparently the pathology diagnosis is pretty straightforward. Cytology at EUS shows these anucleated squamous cells. So if you have a lesion, you think it could be a lymphoepithelial cyst. You don't necessarily have to resect it unless it's very large or the patient is symptomatic. And you could be certain of the diagnosis at EUS by doing this cytology when you see those squamous cells. So who gets these? Most commonly men, adult men, often incidentally, unless they're really big, then they might have symptoms based on mass effect. Primarily visualized as low attenuation or cystic lesions, so they look like cysts, and the key to this, they're very exophytic. Sometimes you can barely tell that they're touching the pancreas, they're that exophytic, so that's a little different than the other tumors I showed you. Often they're misdiagnosed as other things, like maybe a cyst coming from the spleen or the left kidney that just is next to the pancreatic tail. People may not appreciate that it's actually arising from the pancreatic tail. CT appearance can be variable and overlap with some of the other neoplasms, so sometimes you can't be sure. But the classic appearance would be a unilocular cyst or maybe a couple of locules with this thin wall or internal septations and being very exophytic. It has been reported sometimes to have solid components, so in that case, kind of all bets are off. If you're going to see a cystic lesion with mural nodules or solid components, you're going to suggest that it could be a mucinous neoplasm. Okay, so let's look at a couple examples. 47-year-old man with a history of alcohol abuse presenting with weight loss and epigastric pain. So this is the classic appearance. You see a cyst there, but it's just kind of sitting there, right? It's touching the tail of the pancreas. It almost looked like a kidney cyst, right? It's that exophytic. And that's the classic appearance, here you go again, of a lymphoepithelial cyst. It was resected. Pathology confirmed the diagnosis of lymphoepithelial cyst. The patient was symptomatic, remember. Another patient, 37-year-old, history of testicular cancer, who presented with an incidental mass. Okay? Now, sometimes testicular cancer can give you cystic metastasis or cystic lymph nodes. So these tend to be a little bit of an issue in this case. So you can see it looks very much like the other one. This one's in the head, though, and there's one here. And it looks like a kidney cyst, right? It just happens to be touching the pancreas. So there it is again in the axial and a sagittal image. And they do FNA, and they found the squamous cells, so we knew that it was a lymphoepithelial cyst. Another patient, 62-year-old man, incidentally discovered, again, just really looks like a kidney cyst, right? It's even touching the kidney, touching the pancreatic tail. No aggressive features. This is classic for a lymphoepithelial cyst. Another one, 73-year-old, incidental. This one is a little different, right? This one definitely has some internal septations. So this one, if you were showing me the case, I would not say it's a lymphoepithelial cyst. I would say that I would favor this being a mucinous cystic neoplasm because it looks complicated and it has those internal septations. We don't have ductal obstruction, so I'm not going to say it's an IPMN. Doesn't look like an adenocarcinoma. Doesn't look like a serous cystic tumor. So you're going to probably go with an MCN. In this case, you're going to be wrong, but it'd be good for the patient, right? So here again, so that was resected, and again, the pathology confirmed that it was squamous epithelium. So remember, lymphoepithelial cysts are benign lesion. There's no reports of malignant transformation, no reports of recurrence after surgical resection. And just to point out that these aren't really associated with other lymphoepithelial cysts that we think of, like in the head and neck, and those associated with HIV, for example. There's no relationship between the two. Okay, now the last few pearls of lymphoepithelial cysts, remember, rare, more common in middle-aged men, often appear as purely cystic, maybe a little bit of septation, very exophytic, and that's really the key. No pancreatic atrophy, no ductal obstruction. And 3D is important when we're trying to figure out the diagnosis in these, because you're trying to see, is this really a lymphoepithelial cyst? Is there anything suspicious about it that might suggest that it's a mucinous cystic neoplasm? Okay, now we're going to move on to the spens. So solid and papillary epithelial neoplasms. These are also known as solid pseudopapillary neoplasms or Hamoudi tumors. They represent less than 4% of resected cystic pancreatic lesions, so they're pretty uncommon. The key to this is the demographics. They're almost always in women and young women. So if you said to me, Dr. Horton, I have a case of this pancreatic mass in this 29-year-old, I almost don't need to look at it because I'm going to call it a solid and papillary epithelial neoplasm, okay, because that's by far the most common tumor in that age group. They can be very large at the time of diagnosis. They usually are presenting with mass effect symptoms, and treatment is resection because there is a malignant potential. Okay, this is a 43-year-old, so again, young woman, abdominal mass, and there it looks like a pretty aggressive lesion, right? It's pretty big, it's 7 centimeters, it's complex, it has calcification, but this looks very different than the serous cystadenomas, right? This is in the periphery, okay? No ductal dilatation. So based on the age, you're going to say SPEN. If it's not a SPEN, what's it going to be? It's going to be a mucinous cystic neoplasm, most likely. So they resected it, and again, it was a SPEN tumor. 39-year-old, vague abdominal pain. Here we have MPRs and volume rendering, and you see a 6.6 centimeter cystic mass in the pancreatic tail. Okay, there's some septation in there and a solid component. Okay, so if you showed me this, what would I say? Well, I would say mucinous cystic neoplasm. That would be my first diagnosis. Based on the age, it's going to be a SPEN or a mucinous cystic neoplasm. And when it was resected, it was a SPEN. This one looks aggressive. Again, a young female, solid components. These can look very, very complicated because they often bleed. So if you have a nasty, ugly-looking mass like this in a young woman, it's absolutely going to be a SPEN. It could be a mucinous cystic neoplasm, uncommon. It's not going to be the other tumors. Here's another one. The reason it looks like that is there's solid components and also hemorrhage, so you get this low density and high density. And here's another one. This is kind of in the proximal body. Looks complicated, right? It doesn't look like those oligocystic serous cystadenomas or even a mucinous cystic neoplasms. It's like perfect, but there's definitely internal complexity to it. Based on the age, you're going to go with SPEN or a mucinous cystic neoplasm. There's no duct, right? There's no reason to call it an IPMN. Okay, now we have to remember that pancreatic endocrine neoplasms, these are what we used to call islet cell tumors, can look cystic, so you don't want to be fooled by those. They represent 8% of resected pancreatic cystic neoplasms and about 10 to 15% of resected pancreatic endocrine neoplasms are going to be cystic. Most are discovered incidentally. Most are non-functioning or non-hyperfunctioning, I should say. They're all function in a way because all pancreatic endocrine neoplasms produce hormones, but not at a high enough level to cause an endocrinopathy. They occur equally in men and women, generally diagnosed over the age of 60, and these can look complicated. So they're going to be cystic, but the key to these is often the hypervascular rim. They'll get really significant enhancement in the wall. So here's an example. So this is definitely a complicated cystic neoplasm, right? I don't like it for IPMN. I don't like it for serous cystadenoma. Could be a mucinous neoplasm, but the fact that you get that really hyper enhancement of the rim should put a cystic endocrine neoplasm at the top of your list. So this is pretty big. It was 7 centimeters in kind of pancreatic neck region, mural nodules, peripheral calcification, and hyper enhancement of the wall. So that's very, very characteristic. Here's another patient, 43-year-old, asymptomatic. She had MEN1. You have to be on the lookout for those. almost a 5-centimeter lesion, very complicated, right? You can see there's mural thickening, so that's a bad feature. You're going to be worried about a mucinous cystic neoplasm, but because of the degree of enhancement, you should suggest that it's going to be a cystic endocrine neoplasm more likely than a mucinous cystic neoplasm. Both of them are going to be resected, so pathology can sort it all out for you. And here's a little one in the tail. Okay, it's small. There's no ductal obstruction. There's definitely some complexity, especially of the wall. You have the thickening of the wall, the enhancement, and some internal solid components. And again, this was a cystic endocrine neoplasm. Okay, that brings us to the last category. Adenocarcinoma sometimes can look cystic, so you don't want to be fooled by that, but usually it's necrotic, it's not purely cystic. So here's just one example I put in for you. So this is a patient with adenocarcinoma, and you can see because of the necrotic center, it will look low density, and some people would say cystic, but on ultrasound, it's not going to be fluid density, right? It's going to be necrotic tissue. And you can see in this case, there's liver metastasis that also look low in density. Okay, so that's just to keep in mind that sometimes adenocarcinoma can have cystic necrotic change. Okay, in the last couple minutes, we're just going to address what do you do when you find an incidental cyst. Okay, so if it's less than 3 centimeters, no mural nodules, no duct issues, no ductal dilatation, the patient's asymptomatic, you could follow it up. I don't, in my report, suggest the interval of follow-up because I think people, the clinicians, the GI people, the surgeons have their own literature that they use to follow these. But I say what I think it is, and if it's an IPMN, it's less than 3 centimeters, they're going to be following them at a certain interval. Okay, so there are guidelines out there if you're interested, but I don't specifically say advise a follow-up in X number of months. There's ACR guidelines, which are a little different than the ones the surgeon used, so you can look at those. There's some controversy as how do you follow them? Are you following with CT or are you following with MR? With CT, it's excellent to follow these, but again, you might be worried about the radiation if you're following them at frequent intervals on young patients. So you can decide with your surgeons and your clinicians as an institution how you're going to be following these. One of the issues is there's no consensus on growth. So what does it mean to grow? What if it grows a few millimeters over a couple of months? Is that important or not? Right? Is it important? I don't know. It doesn't say if it grows at 3 millimeters in a year, that's an important growth rate. So following them in itself raises more questions. Okay, in the last couple minutes, I'm going to give you a quiz so you can think through what I've said and see if you're going to be right. Okay? So you just have to be calm and try to decide what you think it is. So quiz case number 1. This is about a centimeter cyst sitting in the pancreatic head, and it looks like it's communicating with that dilated duct. Right? So what are you going to say? You're going to say IPMN, right? Perfect location, perfect appearance, and it has communication with the duct. Okay? Number 2, huge mass. Lots of locules, internal septations, central calcification. This is huge, right? Maybe 15, 20 centimeters. Classic appearance of what? Serous cystadenoma, right? Just because it's big, don't let it scare you. It's just huge. And this is why sometimes they'll resect them when they're small, even though they're benign, because they don't want them to get this big. Okay, this one, tail lesion, kind of complicated, right? Has some internal septation, some other kind of maybe soft tissue component coming off the tail. 2 things come to mind, and I want to know the age of the patient. 30-year-old female, it's going to be a SPEN. If you tell me it's a 60-year-old man, I'm going to tell you it's a mucinous cystic neoplasm. Here's one, cyst coming off the tail, very exophytic, unilocular, looks like a kidney cyst, but it happens to be touching the pancreas. That's going to be lymphoepithelial cyst, right? And here we have a cystic lesion off the tail with a very pretty exophytic with a thin internal septation. Here you got to get into the demographics of it, but what this could be is it could be a lymphoepithelial cyst. You could do an EUS, and you could look and see if they have the squamous cells. If the patient's not symptomatic, you could follow it, right? You could see if there's mucin in it. There's no suspicious features. Or this could be a serous cystadenoma, an oligocystic, and that's what it was in this case, an oligocystic serous cystadenoma. So in conclusion, size is important. The size of the cyst may help you decide whether or not you're going to resect it or not. Characterizing the very small cysts is difficult for us in radiology, but EUS is a little bit better. All you can do is remember the demographics, remember what's most common and the classic CT appearance, and look for worrisome features that might change your differential. Is it communicating with the duct, IPMN? Are there septations or nodules? Those are the aggressive features. And also, the clinicians need to correlate it with the patient history and the symptoms, because that's really important to decide whether or not you're going to treat these lesions. Okay, so that concludes our discussion of cystic pancreatic lesions. Thank you.
Hi, this is Shiva P. Raman. I am an assistant professor of radiology at Johns Hopkins, and over the course of this lecture, I'm going to talk a little bit about the CT imaging of solid pancreatic masses. Now, we're going to begin with a very brief introduction, talking a little bit about protocol optimization, and specifically how we at Hopkins choose to image patients with a suspected pancreatic mass. But we're going to spend most of this lecture really going into two major types of pancreatic masses that I think come up most often in clinical practice. We'll start by talking about pancreatic adenocarcinoma, which I think is probably the most important and something you all should be familiar with in your day-to-day practices. And then we'll talk about pancreatic neuroendocrine tumors, the prototypical hypervascular pancreatic mass. Now, for each of these lesions, we're going to talk about staging, how you can help the surgeon determine what's resectable and what's not, as well as a few mimics that potentially could look a lot like an adenocarcinoma or a neuroendocrine tumor. Now, as far as I'm concerned, having proper CT technique is absolutely critical when you're imaging a pancreatic mass. Now, not only is it going to help you in terms of identifying the lesion, but if you don't have the right technique, you're not going to be able to tell what that mass is. Is it an adenocarcinoma? Is it a neuroendocrine tumor? And moreover, you're really going to have trouble telling whether you're dealing with a pancreatic or a peripancreatic lesion. But once you've identified the lesion and figured out what it is, having that proper technique is critical in terms of local regional staging, identifying distant metastatic disease, and providing your clinician that critical information as to whether or not a lesion is resectable or not. Now, our standard pancreatic protocol at Hopkins is a dual-phase study. So any suspected pancreatic pathology, not just a mass, but things like pancreatitis, are going to get a dual-phase study. So typically that entails an arterial phase at roughly 25 to 30 seconds, and then a venous phase at roughly 50 to 60 seconds. Now, note that we do not give these patients positive oral contrast. Not only will that interfere with your 3D post-processing, which we put a lot of emphasis on at Johns Hopkins, but you can also end up with streak artifact and beam hardening artifact that I've seen examples where that artifact can actually obscure lesions in the pancreas. Rather, patients with suspected pancreatic pathology are just going to get a neutral contrast agent, either water or volumen, typically about 1 liter of water or volumen, including some immediately prior to the injection. Now, it is critical that you give a brisk injection of IV contrast, at least 3 to 5 cc's per second, and we give Omnipaque or Visipaque, depending on the patient's renal function. Now, why exactly do you need 2 phases? Now, what's the point? Why not just do a single venous phase like we do for a lot of other things? And there's a couple of reasons for that. First of all, the arterial phase is critical in terms of differentiating vascular tumors, especially neuroendocrine tumors, from pancreatic adenocarcinoma, which tends to be hypodense and most conspicuous on the venous phase. It's also important in cases of neuroendocrine tumors in terms of identifying vascular metastases. Whether it's lymph node mets or liver metastases from a neuroendocrine tumor, they are going to be most evident on the arterial phase. Now, even though arterial phase imaging is most important for neuroendocrine tumors, it is worth noting that there are rare cases where adenocarcinomas will be more conspicuous on the arterial phase, and having both of those phases together increases your odds of catching a subtle tumor. On top of that, even once you've identified the lesion, vascular mapping techniques are going to help you determine vascular tumor involvement, and that's critical for adenocarcinoma, right? The distinction between a lesion with just subtle abutment of the SMA or full 360-degree encasement of the SMA is quite significant in terms of whether or not that patient is resectable. Now, the venous phase images, of course, for pancreatic adenocarcinoma are going to be the most important. The vast majority of adenocarcinomas will be most conspicuous on the venous phase, and identifying metastatic disease, especially to the liver, and local regional lymphadenopathy, again for pancreatic adenocarcinoma, is going to be best done using the venous phase. Now, on top of that, determining a tumor's resectability will always entail looking at the portal veins in the SMV, and that's best done on the venous phase images. And of course, you're not just looking at the pancreas, right? Anytime you're looking at a CT scan, you have to evaluate all of the different solid organs of the abdomen, and that for the most part is going to be best done using the venous phase. Now, you're going to hear many lectures talking about 3D post-processing, and I'm not going to recreate the wheel here, right? I'm not going to talk about each of these different 3D post-processing tools, but what I will say is that I think MIP imaging techniques, vascular mapping, VR, curved planar reformations, all of these have a very important role when you're dealing with pancreatic neoplasms, especially in terms of identifying subtle vascular involvement by tumor. And I'll show you some examples of that during the course of this lecture. Now, why don't we start by talking about what I consider the most important pancreatic neoplasm, and that's pancreatic adenocarcinoma. Now, this is something I see all the time, right? I work at probably the biggest pancreatic cancer referral center in the country. I see, dozens of these cases every week, and I will tell you, having a systematic, algorithmic approach to these cases is critical in terms of making sure you don't miss anything and that you're really picking up on those subtle abnormalities that your surgeon wants to know about. Now, pancreatic cancer is not that common, to be honest. I see a lot of it, but if you look at it overall in the country, there's about 28,000 cases each year, so it accounts for about 2% of all cancers. But that being said, it does account for 95% of all pancreatic exocrine malignancies, and it is the fourth leading cause of cancer mortality. Now, that brings up an important point, right? It's not that common, but it is one of the most leading causes of cancer mortality, and that's because of its very poor prognosis. There is a less than 5% survival at 5 years, and less than 20% of patients are candidates for curative surgery at the time of presentation. Now, for the most part, most pancreatic adenocarcinomas have typical features. These are hypodense tumors that are very poorly marginated. They tend to be infiltrative, and often they will infiltrate posteriorly into the retroperitoneum. These are not well-circumscribed lesions. Unlike the tumor we're going to talk about later, neuroendocrine tumors, it is going to be very difficult for an adenocarcinoma for you to draw discrete margins around the tumor, and in many cases it can be very difficult to actually measure the tumor discretely. Now, not only does this tumor infiltrate, it's often going to have a tendency to encase adjacent vasculature, and it will tend to involve the common bile duct and the pancreatic duct, obstructing both of those. Now, here's a relatively typical pancreatic adenocarcinoma. Notice that it's hypodense, it's poorly enhancing, it is relatively ill-defined and poorly marginated, and you can see that in the second image on the bottom right, it is obstructing the pancreatic duct with abrupt cutoff at the level of the mass. Now, in most cases, you're going to be able to see the lesion, but I will warn you, there are 5 to 10% of pancreatic cancers where you are not going to be able to find the lesion on CT. In these cases, the lesion is going to be essentially isoattenuating to the pancreatic parenchyma on both the arterial and venous phase. And in such instances, you are going to have to look for secondary signs of tumor, which is going to alert you to the presence of an occult tumor. Anytime you see a dilated pancreatic duct, especially where there's abrupt cutoff of the pancreatic duct, anytime you see a dilated bile duct, anytime you see atrophic upstream pancreas, you have to be worried about the possibility of an underlying tumor. In particular, I never let a dilated pancreatic duct go, especially when it's segmental or when there's abrupt cutoff of the duct. Even if I don't see a tumor, that is a tumor until proven otherwise, and that patient needs another test, which is usually going to be an endoscopic ultrasound if you can't identify the mass on CT. Now, here's a relatively classic example, right? You see a hypodense mass, but notice the abrupt cutoff of the distal common bile duct at the level of the lesion. Even if you didn't see the mass, you would have to be worried about the possibility of an occult neoplasm based on the morphology of the duct. Here's another example. Now, in this case, it is very difficult to identify the lesion itself. In fact, I don't really see a primary pancreatic mass. But notice that the pancreatic duct is dilated and there is abrupt cutoff at the level of the pancreatic neck. It doesn't matter that I can't see the tumor. This is a tumor until proven otherwise. This patient needs to go on to get an endoscopic ultrasound, and in fact, they found that this patient had a subcentimeter, very small pancreatic adenocarcinoma. Never let a dilated pancreatic duct go. That has to be further interrogated. Now, CT overall is an excellent modality for pancreatic cancer with sensitivities up to 96%, and certainly we've improved our ability to identify pancreatic cancer on CT, largely because of improvements in scanner technology, thin collimation, better spatial and temporal resolution, and of course our increasing use of MPRs and 3D imaging. Now, when you're putting together a pancreatic protocol, ultimately you're trying to identify pancreatic tumors, and what does that mean? You're trying to maximize the difference in enhancement between the pancreatic tumor and the native pancreatic parenchyma. Now, in most cases, the portal venous phase is going to be the best phase for you to identify pancreatic cancer. But it is worth noting that even though we tend to mostly acquire two phases, the arterial and the venous phase, there actually isn't even, there's a third phase that you could theoretically acquire that gives you maximal pancreatic enhancement and in theory would give you your best odds of identifying a subtle pancreatic mass, and that's the so-called pancreatic phase. Now here's a really nice illustration from an article by Dreisen et al. In Emergency Radiology a couple of years ago, and you can see that the pancreas enhances maximally at roughly about 40 seconds after IV contrast. So just after our traditional arterial phase, but before the traditional venous phase. So if you really wanted to maximize your odds of identifying a pancreatic cancer, you probably would want to acquire that pancreatic phase. Now, we don't do that routinely in practice, largely because if you look at this article by Fletcher et al. In Radiology more than a decade ago, he found that there wasn't really much of a practical difference in terms of how many pancreatic cancers you're going to catch using a portal venous phase as opposed to this quote-unquote pancreatic phase. And for that reason, we don't want to scan the patient with 3 or 4 different phases in every case. For the most part, we just acquire 2 phases. We get an arterial phase and we get a venous phase, and we don't routinely acquire this pancreatic phase. Now, one of the things I see all the time when I'm working with residents is that they tend to try to talk about resectability in their dictation. And they say this is a resectable tumor, this is an unresectable tumor. And I would strongly advise you against using those terms in your dictation. Resectability really is going to be variable depending on where you work, your individual surgeon, patient factors, do you have a pancreatic cancer clinic, and a lot of other factors that I think are difficult for us as a radiologist to really figure out just based on the CT scan. In general, I think you want to report certain features that your surgeon is going to use in order to determine whether that patient is ultimately going to be resectable or not, but I don't personally use the term resectable or unresectable in my dictations. Now, that being said, determining resectability is absolutely critical, right? If you correctly determine a lesion to be resectable, the survival after surgery is typically going to be about 15 to 20% at 5 years. Now, that's still bad, but at least it gives the patient a chance. On the other hand, if a patient is incorrectly thought to be resectable, so let's say you present data that says the patient is resectable based on the CT scan, but they find that the patient is actually unresectable at surgery because there's an occult liver met or an occult peritoneal carcinomatosis, then they've basically undergone the Whipple procedure for no reason. Survival after a Whipple procedure in a case where the tumor is incorrectly thought to be resectable is no better than chemoradiation alone. So you really want to avoid doing Whipple procedures in patients who really, where it wasn't indicated. Now, when you're trying to figure out whether a patient is resectable, the first step is to figure out whether or not they have metastatic disease. Pancreatic cancer, by far the most common location for metastasis is going to be the liver, and you really have to look at the liver very, very carefully in these patients to make sure you're not missing a subtle metastasis. Local regional nodes are commonly involved, but in general, big, bulky, obviously metastatic nodes are not that common. And oftentimes we have a lot of difficulty in terms of figuring out whether a node is metastatic or not. Carcinomatosis, again, very common, but we tend to miss it quite a bit. And I'd say lung is probably going to be the 4th most common site. Now, in general, I tell our residents and fellows, don't worry so much about metastatic lymphadenopathy. Local regional nodes, for the most part, will not affect the decision as to whether the patient goes to surgery or not. The only things you do need to worry about are whether there's distant lymphadenopathy, so well away from the pancreatic bed, or alternatively, local regional nodes that are extensive, big, bulky, centrally necrotic. Those kind of nodes can potentially affect a patient's resectability. Now, unfortunately, as with many other types of tumors, the sensitivity of CT for metastatic nodes is pretty low, right? We're ultimately going to be looking at size criteria which are inherently limited in terms of the sensitivity and specificity, but I wouldn't worry too much. Whether or not you call the nodes metastatic or not isn't going to matter. Most of the time, these nodes are going to be generally sampled and resected at surgery. Now, lymphadenopathy doesn't matter so much. Distant metastatic disease is critical. As I mentioned, distant metastatic disease automatically will make the patient unresectable. So if you have a liver metastasis, you have obvious signs of carcinomatosis, that patient is not going to go to the operating room. Now, the venous phase images are absolutely critical in terms of determining the presence of metastatic disease, especially to the liver. Remember, the portal venous phase gives you maximal enhancement of the liver and is going to be the best phase to identify these subtle hypodense liver mets. Now, you're not just looking for big, obvious 2 or 3 centimeter mets. You really need to look carefully for these subtle subcentimeter lesions that could potentially represent metastatic disease. Now, even though the venous phase is going to be the best for identifying subtle liver mets, I do recommend that you look at the arterial phase as well. These small lesions often can be difficult to distinguish from a small cyst or a small hemangioma, but the presence of a perfusion anomaly or a THAD surrounding the liver lesion on the arterial phase can be a strong clue that you're dealing with something malignant rather than benign. Now, as with other malignancies that metastasize to the liver, CT is quite good for lesions that are over a centimeter with sensitivities well over 90%, but the sensitivity and specificity drops quite rapidly for lesions that are sub-centimeter. And unfortunately for sub-centimeter lesions, sometimes you're going to be stuck saying that it's too small to characterize, and you may need to just follow those lesions over time or get an MRI if there's a very strong clinical suspicion. Now, as much as we have problems with liver metastases, we have a lot of problems identifying carcinomatosis. Our sensitivity, if you look not just for pancreatic cancer, but for a number of malignancies, is the sensitivity is probably well under 50%, probably closer to about 25%. Unfortunately, even in cases where there are macroscopic tumor implants, they can blend in with adjacent anatomy, and I've seen plenty of cases where, in retrospect, you can identify the carcinomatosis, but it was very difficult to identify prospectively. Unfortunately, I'd say in terms of things that we don't catch on CT that lead to a patient being determined as being thought to be unresectable at surgery, I'd say missed carcinomatosis is probably going to be the most common, and this is something that you can't avoid. We're all going to miss carcinomatosis. Sometimes you're just not going to be able to see it on the CT scan. So here's a patient who has a big pancreatic cancer in the pancreatic head. Notice that there are multiple hypodense metastases throughout the liver. Clearly, this patient is unresectable. There's no question here of going to surgery. This patient is going to get chemotherapy and is going to have a dismal prognosis. Now, as I mentioned, carcinomatosis can be quite difficult, and you've got to be on the lookout for pretty subtle findings. Anytime I see ascites in a patient with pancreatic cancer, I'm going to spend extra time looking at the omentum and the mesentery. Ascites has to be taken as your #1 clue that there's something going on in the peritoneum, and you need to look carefully for any stippling, any nodularity, any unexplained stranding or induration in the omentum that could reflect the presence of an underlying pancreatic adenocarcinoma. Now, once you've determined the presence or absence of metastatic disease, the next step is to identify the presence or absence of vascular involvement. Now, as I mentioned before, it can be very difficult determining whether a patient is resectable or unresectable from the perspective of a radiologist. And that's largely because now there's blurred margins between what truly is resectable and unresectable. Now, in the old days, if you had really any vascular involvement at all, you were pretty much determined to be unresectable, right? There was no question as to if you had subtle SMA involvement or subtle celiac artery involvement. Essentially, those patients were not going to the operating room. Now, on the other hand, over the course of the last decade, we've now seen this new category of so-called borderline resectable disease. So these are patients who have some degree of vascular involvement, in some cases pretty significant vascular involvement. And they're still potentially operative candidates, usually after a round of chemotherapy and radiation. Now, the definition of borderline resectable will vary a little bit from surgeon to surgeon, from institution to institution, but this slide really lists kind of the classic definition of borderline resectable. So you are potentially still a candidate for surgery if you have tumor that abuts less than 180 degrees of the SMA, if you have short segment encasement or abutment of the hepatic artery, or even if you have very significant SMV or portal vein involvement that's amenable to surgical reconstruction, often with some kind of a jump graft. Now, again, that gets into a level of complication that I don't think you should think about too much when you're actually dictating these cases. Your job as a radiologist is really to present the data and allow the surgeons, allow the oncologists to determine whether or not they want to take the patient to the operating room. But I will say the information that they need really hinges on five vessels. You need to report in every case what the tumor is doing or the relationship of the tumor with the portal vein, the SMV, the portal SMV confluence, the celiac trunk, the hepatic artery, and the SMA. That's what the surgeon needs to know. They want to know, are those vessels involved, and if they are, to what degree? Now, when you're talking about the arteries, you want to report in terms of degrees of involvement. So you're trying to differentiate those tumors that have less than 180-degree involvement of the artery circumference from those that have over 180 degrees of an artery circumference. So in order to clear a vessel, you're looking for a preserved fat plane around the margin of the artery. Now, when you're reporting involvement of the portal vein in the SMV, I tend not to use that degree nomenclature like I do for the arteries. Now, for the portal vein SMV, you really want to give some kind of a verbal descriptor that the surgeon can use to determine whether or not venous reconstruction is technically feasible. Because as I mentioned earlier, venous involvement nowadays isn't quite as much of a barrier to surgical resection, because the surgeons can really do a lot of things in terms of dealing with the vessel, jump grafts and other reconstruction techniques. So venous involvement isn't quite as big a deal. Here's a good example of a patient who has significant venous involvement. You can see that there's about a 3 to 4 centimeter segment of the SMV that's quite narrowed all the way up to the portal SMV confluence. Here's another example. Again, you can see that there's a hypodense tumor in the pancreatic head and neck, and there is significant stenosis not only of the distal main portal vein and confluence, but the superior SMV as well. Give a verbal description and let the surgeon decide whether or not the patient is resectable. Now, arterial involvement, again, you want to be more exact. Here's a patient who has encasement of the celiac artery, so my dictation would say that there is 360-degree encasement of the celiac, and there is clearly some involvement of the hepatic artery as well. Here's another example. SMA, you can see that there's 360-degree encasement of the SMA over a relatively long segment. The vessel looks attenuated and narrowed. Now, even though we're operating on more and more patients nowadays, there's virtually no surgeon I know of who's going to operate on a patient with 360-degree SMA involvement like this. This is almost certainly going to be unresectable. Now, it's important to remember that the other vessels don't really matter so much, okay? So you're really concentrating on those 5 vessels that I talked about earlier, and smaller vessels like the GDA, well, that's not a big deal. Here's an example where the GDA is actually encased by tumor, but that doesn't matter. The GDA is going to come out as part of the surgery. This is not going to preclude the patient from getting resected. Now, how good is CT ultimately in terms of determining whether a pancreatic cancer is resectable or not? And the answer is that CT is actually quite good for establishing unresectability. So based on a CT scan, I can tell you with a very high degree of certainty that a patient should not go to the operating room. So the positive predictive value for unresectability may be as high as 100%. The problem is that what you're really trying to figure out is whether or not that patient is resectable. So you're trying to figure out and tell the surgeon, is that patient ultimately capable of undergoing an R0 resection? So in other words, a resection with negative surgical margins. The problem is that we still struggle with this, even with the latest generation of CT scanners. Somewhere between 60 to 91, only 60 to 91% of patients, or 60 to 91% of patients who are deemed to be resectable based on CT are ultimately found to be unresectable at surgery, and only a quarter of patients deemed to be resectable are found to be resectable at surgery. And what are we missing? We're missing small liver metastases, we're missing subtle vascular involvement, and we're missing tiny peritoneal implants. Now, I talked earlier about some of the typical features of pancreatic cancer. What are some features on a CT scan that should suggest the presence of a diagnosis other than pancreatic ductal adenocarcinoma? So in other words, what are some features that should suggest that you're dealing with a mimic of pancreatic cancer? First of all, as I mentioned earlier, pancreatic cancer will almost always obstruct the ducts. So if I see a tumor in the pancreatic head that is not obstructing the common duct or the pancreatic duct, I'm going to look at it with a little bit of cynicism, right? Am I dealing with something else that's potentially mimicking a pancreatic cancer? Similarly, if I see a big mass in the pancreatic head, but the upstream pancreas is not atrophic, again, that is a quite atypical feature and should make you think of another diagnosis. Remember, pancreatic cancer will tend to surround vessels and often will tend to encase and narrow those vessels. So if I see a big mass that's encasing the portal vein in the SMV, but there's really no narrowing, there's no occlusion or attenuation of the vessel, that should suggest another diagnosis. And then finally, pancreatic cancer commonly metastasizes to lymph nodes, but it is relatively uncommon for you to see big, bulky locoregional nodes. If you do see that, you see massive lymphadenopathy, you should think about another diagnosis, and usually that's going to be lymphoma. So what are some of the mimics that you need to be thinking about in your day-to-day practice? I'd say the big ones are going to be lymphoma, focal autoimmune pancreatitis, peripancreatic lymphadenopathy from another primary, duodenal tumors, groove pancreatitis, and fatty infiltration of the pancreatic head. Now, of all of these, the one diagnosis that I'd say comes up all the time, and we get cases referred in from outside institutions with quote-unquote pancreatic cancer, and it turns out to be fatty infiltration of the pancreatic head, aka pancreatic lipomatosis. I can't tell you how many cases I've seen that were billed as being a pancreatic cancer, but that just turned out to be focal fat. Now, in most cases, fatty infiltration of the pancreas will be diffuse, but it can rarely be focal, and it tends to have a predilection for the anterior aspect of the pancreatic head. And I've seen cases where, even someone like me who sees a lot of this on a day-to-day basis, I've been uncertain as to whether or not I was dealing with a primary pancreatic mass. But there are some features that should make you think that you're dealing with fatty infiltration. First of all, it tends to have very geographic margins. It's going to involve the anterior aspect of the pancreatic head, and there's going to be a straight line demarcating that hypodense part of the pancreas from the more normal appearing pancreatic parenchyma posteriorly. On top of that, it's not going to act like a tumor. You're not going to see mass effect, there's no dilated ducts, there's no deformity of the pancreatic contour, it's not going to do anything to the surrounding vessels. Now, I'd say in most cases, if you think about the possibility of fatty infiltration, this is not going to be a difficult diagnosis, but in those rare instances where you're truly not certain, just go on to get an MRI. An MR with in and out of phase chemical shift imaging is going to make this very easy to diagnose. The area of fatty infiltration is going to lose signal on the out of phase. Here's a good example. You can see that there's superficially something that looks like a hypodense lesion in the pancreatic head, but it's geographically marginated. There's a straight line separating the hypodense area from the posterior aspect of the pancreatic head. There's no mass effect, no dilated ducts. And the more you look at it, the more you realize it doesn't really look mass-like. This is classic fatty infiltration. Now, I'd say the second most common mimic that I see in my practice is going to be lymphoma. Now, it is worth noting that primary pancreatic lymphoma is actually really rare. It's less than 1% of all pancreatic tumors. Usually it's diffuse large B-cell lymphoma, and you're going to see it in immunocompromised patients or the extreme elderly. And honestly, it's so rare that I've seen very few cases of it. In fact, I think I've seen one case that was truly thought to be a primary pancreatic lymphoma. Now, secondary lymphomatous involvement of the pancreas, on the other hand, tends to be much more common, right? And this is actually not that uncommon, at least in my practice. And I have a handful of cases that I've seen just over the last year. Now, lymphoma can superficially look like a pancreatic cancer. It's going to be hypodense, poorly marginated. It's going to look relatively poorly enhancing. And it does have a tendency to involve the pancreatic head. But there are some features that should make you think of something else. First of all, it will often surround vessels, but there's going to be absolutely no vascular narrowing, no evidence of occlusion. It's not going to really ever narrow or attenuate the vessel. Secondly, unlike pancreatic cancer, which almost always infiltrates posteriorly into the retroperitoneum, lymphoma will infiltrate without any regard to anatomic boundaries. So it can infiltrate both anteriorly and posteriorly, which is quite uncommon. And then finally, as I mentioned before, pancreatic cancer is almost always associated often will metastasize to lymph nodes, but massive lymphadenopathy is uncommon, whereas with lymphoma, big-time lymphadenopathy is going to be very common. So here's an example. Here's a patient with a big mass that's encasing that's surrounding the entire pancreas. Easy to think that this is pancreatic cancer, but it doesn't look like any pancreatic cancer I've ever seen, right? It is involving multiple different organs. It's encasing vessels, but notice how the SMA and the splenic artery are absolutely going through this tumor unimpeded, unattenuated. There's massive lymphadenopathy. There's a big splenic mass. This is not a pancreatic cancer. This is diffuse large B-cell lymphoma. Now, it is worth noting that leukemia in its focal form, so-called chloroma or granulocytic sarcoma, can look identical to lymphoma, and you can rarely end up with leukemic infiltration of the pancreas. Here's an example of that. Big hypodense mass in the pancreatic body/tail segment. This turned out to be a chloroma. Now, another diagnosis that I'm increasingly seeing in my practice, or at least that we're becoming increasingly cognizant of, is autoimmune pancreatitis. Now, autoimmune pancreatitis usually is going to diffusely involve the pancreas, right? The pancreas is going to be diffusely enlarged. You're often going to see a low attenuation halo around the pancreas. You may see delayed enhancement of that halo, and often there's associated autoimmune IgG4-related cholangitis. So you may see strictures of the CBD, usually with thickening and enhancement of the distal CBD at the level of the ampulla. The problem is that autoimmune pancreatitis can rarely be focal. It can involve portions of the pancreas especially the head, and can look very much like a pancreatic cancer. Here's an example. Mass in the pancreatic head. Notice that it's not obstructing the pancreatic or the common bile duct, so that's the feature that should make you think that you're probably not dealing with a pancreatic cancer. But to be honest, in cases like this where you have a very focal form of autoimmune pancreatitis, it can be virtually impossible to really exclude the presence of an underlying malignancy. Now, here's another entity that I think many people are not familiar with but can theoretically mimic pancreatic cancer, and that's groove pancreatitis. Now, this is a rare form of chronic pancreatitis that's going to affect the pancreatic or duodenal groove, the space between the pancreatic head, the duodenum, and the common bile duct. Now, this is a rare entity, extraordinarily difficult in terms of making the diagnosis based on imaging, and is usually, most often seen in patients who have other risk factors for chronic pancreatitis, especially alcoholism. Now, the imaging features can look a lot like pancreatic cancer, but there are some features that may at least make you think about this diagnosis prospectively. You're looking for sheet-like curvilinear hypodense soft tissue in the pancreatic or duodenal groove, usually with smooth tapered narrowing of the distal CBD and the pancreatic duct, but no stigmata of traditional edematous pancreatitis. You're not going to see inflammatory change, you're not going to see free fluid. It's going to look kind of like sheet-like tumor. Now, over time, these patients do have the traditional risk factors for chronic pancreatitis, so they will develop the traditional stigmata, including calcifications, dilated pancreatic duct, beading, and irregularity. Here's an example. You can see that there's this sheet-like curvilinear soft tissue in the pancreatic or duodenal groove. It is mildly obstructing the pancreatic and common bile ducts. Very hard to say that that's not a pancreatic or a duodenal malignancy. Here's another example, again, subtle soft tissue in the groove between the pancreas and the duodenum. There is some subtle cystic change within that soft tissue, which is not uncommon in these cases, but honestly, very difficult to say that that's not malignancy. Most of the cases of groove pancreatitis that I've seen have ultimately been operated on because it's very difficult to exclude the presence of an underlying malignancy, even with a negative biopsy. Now, why don't we move on now to our second major category of pancreatic masses, and we'll talk a little bit about neuroendocrine tumors. These have a number of different names. Often, many of you probably are familiar with the term islet cell tumor. I think we typically use the term neuroendocrine tumor nowadays. And these are tumors composed of well-differentiated endocrine cells. In the old days, we categorized these as being either functioning or non-functioning, but now we recognize that all neuroendocrine tumors are hormonally active, and so we tend to categorize them as being syndromic or non-syndromic based on whether they secrete enough hormone to cause laboratory and clinical findings. Now, there are a number of associations of neuroendocrine tumors with different syndromes. I'd say the most common that I come across in my practice are von Hippel-Lindau, neurofibromatosis, and MEN type 1. There's also a theoretical association with tuberous sclerosis. Now, syndromic NETs, or neuroendocrine tumors, are clinically evident lesions because the mass is producing enough hormone to actually cause an endocrinopathy. Now, because these lesions are causing symptoms, they tend to present when smaller. Now, even though we tend to think of these as just secreting one hormone, it's worth noting that syndromic NETs will often secrete multiple hormones, but it's the dominant hormone that's actually going to establish the patient's syndrome. Now, because these patients do tend to present earlier, the lesions tend to be smaller, so most often under 3 centimeters in size. There are a number of different syndromic NETs that have been described: insulinomas, glucagonomas, gastrinomas, VIPomas, somatostatinomas, and so on and so forth. But the two most common types by far in our practice are insulinomas and gastrinomas. Now, insulinomas tend to be small and they tend to be relatively benign. Only 10% are malignant. They're associated with the classic clinical symptoms of Whipple's triad: hypoglycemia, symptomatic hypoglycemia, and symptom improvement after the administration of glucose. Now, gastrinomas, on the other hand, are much more often malignant. About 30% will present with liver metastases. They're often multiple, and they are not uncommonly extrapancreatic. So not only do they arise in the pancreas, they can arise in the so-called gastrinoma triangle. Now, these patients will often end up with peptic ulcer disease, ulcers in unusual locations, especially post-bulbar duodenal ulcers, and they can present with so-called Zollinger-Ellison syndrome. Now, non-syndromic NETs, on the other hand, account for about 50% of all neuroendocrine tumors, and because they're not producing endocrinopathy and symptoms when smaller, they tend to be quite large when they present. And so the average size is about 5 centimeters. Now, the symptoms in these patients tend to eventually occur when the lesion gets large enough and you end up with mass effect, metastatic disease, and local invasion. Now, these tumors tend to look ugly and aggressive, right? So they are much more likely to be cystic, necrotic, they can have calcification, and they can just generally look aggressive with the presence of distant metastatic disease. Now, how do I tell whether a lesion is a neuroendocrine tumor or a pancreatic cancer? And the truth is that in most cases, it's going to be pretty obvious. First of all, neuroendocrine tumors will avidly enhance on the arterial phase, and they'll typically still be hypervascular on the venous phase as well. And that's something you're never going to see with an adenocarcinoma, which is going to be hypodense on all phases. Now, the arterial phase is going to be the most critical for identifying most pancreatic neuroendocrine tumors, but it is worth noting that in rare instances, you will see NETs that are more conspicuous on the venous phase. But I'd say as important as the enhancement pattern is, the degree of the margins of the tumor are just as important for making the diagnosis. In most cases, even if I don't have an arterial phase, just the margins of the mass on the venous phase will tell me whether I'm dealing with an adenocarcinoma or a neuroendocrine tumor. Adenocarcinomas are poorly marginated and ill-defined, often very difficult to discretely measure. Neuroendocrine tumors are well-circumscribed lesions. They have clear margins. You're going to be able to see you're going to be able to clearly demarcate what's tumor and what's the adjacent peripancreatic fat. Now, these lesions can rarely be cystic or necrotic, and in fact, they can be so cystic that they can mimic other primary cystic lesions of the pancreas, like an IPMN. But in those cases where there's a significant cystic or necrotic component, there's almost always going to be a surrounding rim of hypervascular soft tissue, which should allow you to make the right diagnosis. Now, unlike a pancreatic cancer or pancreatic adenocarcinoma, neuroendocrine tumors, you typically will not obstruct either the pancreatic or biliary ducts. Now, that being said, large tumors can cause obstruction, and there is a small category of neuroendocrine tumors that, even though they're quite small, will secrete serotonin and other similar hormones that can cause fibrotic stricturing of the ducts. So even though most cases you're not going to see biliary pancreatic ductal obstruction, it can happen. You're almost never going to see upstream pancreatic atrophy, and it is not uncommon for you to see big, bulky local regional nodes, and those nodes are often going to be hypervascular on the arterial phase. So here's a chart really comparing and contrasting the imaging features of a neuroendocrine tumor and an adenocarcinoma. Remember, neuroendocrine tumors are well circumscribed, unlike the poorly marginated adenocarcinoma. In most cases, they are avidly enhancing and will be best seen on the arterial phase, unlike adenocarcinomas, which are hypovascular and best seen on the venous phase. Neuroendocrine tumors, interestingly, will invade the venous vasculature. So if you see a mass in the pancreas that's invading the SMV or the portal vein, that is almost never going to be a pancreatic adenocarcinoma and is usually going to represent a neuroendocrine tumor. Adenocarcinomas, on the other hand, will encase and narrow the mesenteric veins. Now, adenocarcinomas almost never calcify. In fact, virtually never calcify in the absence of treatment, whereas neuroendocrine tumors commonly calcify, and that calcification can be either central or diffuse. Now, as I mentioned, pancreatic adenocarcinoma will typically not give you big, bulky local regional nodes, whereas neuroendocrine tumors will often give you enlarged local regional lymphadenopathy. And of course, the metastatic disease is going to have the same enhancement pattern as the primary. So neuroendocrine metastases are going to be hypervascular and best seen on the arterial phase. Adenocarcinoma metastases are going to be hypovascular and best seen on the venous phase. So here's a classic pancreatic neuroendocrine tumor. Well circumscribed, well marginated. You can clearly demarcate the mass from the adjacent peripancreatic fat. And notice that it is avidly hypervascular on these arterial phase images. Notice also there is absolutely no upstream pancreatic atrophy, which would be quite unusual for a pancreatic cancer in this adenocarcinoma in this location. Now, we are increasingly, as we do more and more arterial phase imaging for a number of different indications, identifying small neuroendocrine tumors incidentally. Here's an example of that. This is a small neuroendocrine tumor, probably 6 or 7 millimeters, completely incidental finding in a patient who's being scanned, I think, for looking for a renal mass. Here's another example. Again, very small hypervascular lesion. Here's an example really illustrating that you still have to look for hypervascular lesions in the pancreas, even on the venous phase. Although they're typically most evident on the arterial phase, there are examples like this one where you're going to be able to make the diagnosis on the venous phase images as well. Now, as I mentioned, non-syndromic neuroendocrine tumors tend to be quite large. They look more aggressive, more likely to have cystic and necrotic change. Here's a big non-syndromic neuroendocrine tumor. Patient didn't have any evidence of endocrinopathy, but they ultimately came to clinical attention because of local mass effect and invasion from the tumor. Now, one of the things I'm always thinking about when I'm dealing with a pancreatic cystic lesion is, am I missing one of those rare cystic neuroendocrine tumors? Here's 3 examples. Now, in each of these 3 cases, I think it would be very easy to just say, well, okay, it's a small cyst in the pancreas. It's probably a small side branch IPMN. Who cares? Move on to the next case. But in each of these 3 cases, you'd be missing a quite significant diagnosis. Notice that these are not simple cysts. There is a rim of dense, irregular enhancement and soft tissues surrounding the margins of each of these cysts. Notice that the lesion in the bottom image actually has a large soft tissue component that's hypervascular. Anytime you see a hypervascular rim or soft tissue associated with a pancreatic cyst, you have to think about a cystic neuroendocrine tumor. Now, sometimes rather than just seeing a cyst, you're going to see actual necrotic degeneration. It tends to be more common with non-syndromic lesions, but can occur in syndromic lesions as well. Here's an example where you see there's a significant necrotic component, but again, that hypervascular soft tissue associated with the lesion is going to drive you towards the right diagnosis. Now, one of the things I always tell our residents and fellows, if you see a calcified pancreatic mass, you are not dealing with an adenocarcinoma, period. Never happens. On the other hand, this is quite common with neuroendocrine tumors. These calcifications in certain instances can be very diffuse, as in this case, or can be stippled and involve just a part of the lesion. But anytime you see a calcified solid pancreatic mass, you have to be thinking about a neuroendocrine tumor. Now, look for other signs as well. Here's a case where I actually didn't at first see the pancreatic lesion, right? And if you look at the bottom image, it's quite subtle. Even on arterial venous phase, you can kind of vaguely see that there's something there in the pancreas. But notice that there's this dramatic wall thickening of the stomach, right? It's involving the proximal and mid portions of the stomach, and that wall thickening of the stomach actually looks dramatically hypervascular. This is the classic distribution and the classic appearance of Zollinger-Ellison syndrome. The second I saw that, I went back, looked at the pancreas much more carefully, and we were able to identify this very subtle pancreatic neuroendocrine tumor that I think I wouldn't have seen if I hadn't seen the gastric findings first. Now, as I mentioned earlier, pancreatic cancers will tend to encase and narrow or even occlude the mesenteric vasculature. That doesn't tend to happen with neuroendocrine tumors. They tend to invade the mesenteric veins. Here's an example where you have a pancreatic neuroendocrine tumor in the pancreatic tail. It's invading and distending the entire splenic vein with tumor. You know that this isn't a pancreatic cancer. They don't do that. This has to be a neuroendocrine tumor. Here's another example. Again, you can see this large mass involving much of the pancreas. It's invading the portal vein and the splenic vein, distending those vessels. And notice on the coronal MIP arterial phase reconstruction, there's dramatic hypervascularity within the tumor thrombus, classic neuroendocrine tumor. Now, as I mentioned, metastatic disease, either from a neuroendocrine tumor or an adenocarcinoma, will have the same enhancement pattern as a primary tumor. Here's a patient who has a big hypervascular pancreatic neuroendocrine tumor. Notice that the liver metastasis looks virtually identical and has lots of internal neovascularity. Now, neuroendocrine tumor liver mets can be quite small. They can be miliary in terms of their appearance. They can look subcentimeter. And this is one of the reasons why I really think MIP imaging is critical. I always use MIPs to look at the liver in any patient with a hypervascular primary. It can really make those subtle, small, early neuroendocrine tumors metastases stand out and become much more obvious. Now, just as we talked about a few mimics for pancreatic adenocarcinoma, there are several mimics of pancreatic neuroendocrine tumors. I'd say the most common mimic, and the one that comes up actually relatively frequently in my own practice, is metastatic disease to the pancreas, and classically renal cell carcinoma. Now, renal cell carcinoma can metastasize to the pancreas years after initial presentation, and because these are, again, fundamentally hypervascular tumors, especially with clear cell RCCs, a hypervascular met to the pancreas from an RCC will look indistinguishable from a neuroendocrine tumor based on the imaging alone. And so what's going to drive you towards the right diagnosis is going to be the patient's history. Here are 2 examples. The first, in the upper left, is just a small hypervascular lesion, could easily be a neuroendocrine tumor. And the second is a more dramatic case in the bottom right, where there are innumerable hypervascular lesions throughout the pancreas. Now, in both instances, if you were to tell me these are neuroendocrine tumor lesions, I would believe you, right? That's all comers going to be the most common diagnosis. But what's the clue here on each of these images that that's not the right diagnosis? Notice that the kidney is missing. The right kidney is missing in both cases. This patient has had a nephrectomy. These are renal cell carcinoma metastatic lesions. Now, the second mimic, and the one that I'm always worried about mistaking for a neuroendocrine tumor, is an intrapancreatic splenial. I've worked at 3 institutions, and at every institution I've been at, I've seen a case where an intrapancreatic splenial has been taken to the operating room because it was mistaken for a neuroendocrine tumor. Believe me, this is actually easy. This is an easier mistake to make than you'd think. After all, the pancreatic tail is the second most common location for an accessory spleen, and especially when you're dealing with just a single venous phase abdomen, very easily confused for a neuroendocrine tumor. But that being said, there are a few clues that may help you. Remember that an intrapancreatic splenial should have identical enhancement to the spleen on all phases of contrast, so it'll have that characteristic tiger stripe pattern on the arterial phase. And a neuroendocrine tumor, a splenial will never be more than 3 centimeters medial from the pancreatic tail. So if you see a lesion that's more than 3 centimeters medial from the tail, you're dealing with a neuroendocrine tumor. You're not dealing with a splenial. Now, I would say the key to making this diagnosis is to just think about the diagnosis, okay? When you make this mistake, it's usually because you don't even consider the possibility of a splenial. If you're not sure, this is one of those instances where you've got to get another test. Get a sulfur colloid Tec-99 scan or a heat-denatured RBC scan, just to make absolutely certain that you're not sending the patient to the operating room for what is fundamentally a benign lesion. Here are 2 examples, and I'll tell you, both of these lesions are accessory spleens. One of them ended up going to the operating room and was unfortunately found to be an accessory spleen in the OR, but was thought to be a neuroendocrine tumor. But you can see in both instances, if you had thought about the possibility, this is a major mistake that you might have been able to avoid. So just think about it, and if you've thought about it, you're probably going to be able to recommend the next best appropriate step. Now, there are some more rare lesions that can mimic a neuroendocrine tumor as well. Here's a relatively uncommon lesion, a solid serous cystadenoma. Now, you are all familiar with the classic serous cystadenomas, which are honeycomb lesions, multiple small cystic spaces. They have a central scar, a central calcification. But there are cases where serous cystadenomas can have virtually no cystic component and can look solid, so-called serous adenomas. And they are hypervascular lesions that will avidly enhance and look identical to a neuroendocrine tumor. This is a virtually impossible diagnosis to make on CT, and frankly, I'd say that if you read enough of these, you're ultimately going to make this mistake, right? These lesions almost always are resected. There's really no way around making this mistake. What about peripancreatic GI stromal tumors? Now, GI stromal tumors can be found anywhere in the GI tract, tend to be more common in the stomach, but when you do see them in the small bowel, they tend to be most common in the second portion of the duodenum. Now, GI stromal tumors can be very variable in terms of their enhancement pattern, but they can be relatively hypervascular on the arterial phase, and they can look a lot like a neuroendocrine tumor. Now, the key to making the right diagnosis in these cases is to look for a fat plane between the mass and the pancreatic head. So in other words, figuring out that you're dealing with a peripancreatic lesion rather than a primary pancreatic lesion. But that being said, if you're not certain, it doesn't really matter. The treatment's going to be the same regardless of whether it's a neuroendocrine tumor or a GI stromal tumor. The same surgery is going to happen. It's going to be a Whipple procedure. It's not going to be critical that you make the you correctly identify a differentiated GIST from a neuroendocrine tumor. Finally, here's another peripancreatic lesion that can look a lot like a neuroendocrine tumor, peripancreatic paragangliomas. Again, it's great if you're able to figure out that these are extrapancreatic and you're able to identify that fat plane between the pancreas and the mass. But once again, these are surgical lesions. Even if you're not able to make the diagnosis prospectively, as long as you're able to point the surgeon in the right direction and say that this is a lesion that needs to come out, you've done your job. Now, when you're talking about pancreatic NETs, I'd say in most cases, it doesn't matter whether you're able to differentiate one of these mimics from an NET, because the treatment's going to be the same. All of them are going to get the same surgical procedure, so accurate preoperative diagnosis isn't really going to change management. But the one diagnosis you cannot miss, the one diagnosis that is really going to make you look bad in front of your referring surgeons, is going to be when you misdiagnose a splenial as an NET. So anytime you see a neuroendocrine tumor near the tail, or what you think is a neuroendocrine tumor, sit back at least for a minute, think about the possibility that it could be a splenial, and decide whether or not you want to get a nuclear medicine study for confirmation. So in summary, hopefully I've shown you that it doesn't matter how good you are, how much you know about the pancreas. If you don't have the right protocols in place, if you're not using dual-phase technique, it can be very difficult to make the correct diagnosis and really give the surgeon the information they need to determine whether a lesion should come out or not. I think it's pretty much mandatory nowadays that any pancreatic imaging, regardless of what suspected pancreatic diagnosis you're looking at, requires dual-phase technique with both arterial and venous phase imaging. Secondly, when you're looking at these cases, I think it's really important that you understand the role of CT in terms of both diagnosing and staging pancreatic cancer. It's not enough when you're looking at a pancreatic cancer case to just say to your surgeon, well, there is a cancer there, period, right? You have to give your clinician the information that they need in order to determine whether that lesion is resectable or not. Always be thinking about mimics, right? Because a lot of these mimics are not going to be surgically treated. If you have lymphoma or autoimmune pancreatitis, those are potentially non-surgical cases, and it's great if you're able to make the diagnosis prospectively and save the patient an unneeded surgery. Finally, always look at the pancreas very carefully in the arterial phase images for small hypervascular lesions. The arterial phase is the most critical phase for diagnosing pancreatic neuroendocrine tumors, and we're increasingly identifying these lesions on dual-phase studies being done for other reasons. So why don't we end there, and thanks everyone for listening. Hi, this is Shivaraman. I'm from Johns Hopkins University in the Department of Radiology, and we're going to talk a little bit about computed tomography after pancreatic duodenectomy. We'll talk about normal findings and some complications that you should be looking out for. Now, complications of the Whipple procedure, we'll start a little bit by talking about the surgical procedure itself, including the anastomoses and how the procedure is performed. We'll talk a little bit about CT technique, including how we typically image patients at Johns Hopkins who have had a prior Whipple procedure. And we'll talk a little bit about normal findings, things that you shouldn't confuse with pathology, both in the acute perioperative period and when performing chronic surveillance. But we'll spend most of the lecture really going into a number of different complications that you might encounter when you're imaging these patients after they've undergone a Whipple. Now, the Whipple procedure, so-called pancreatic duodenectomy, is the most common procedure utilized today for resection of tumors in the pancreatic head, uncinate process, and neck, as well as for lesions that occur in the duodenum, the extrahepatic bile duct, or in the ampulla. Now, for many, many years, the Whipple procedure was a dreaded surgery, right? Massive mortality, huge morbidity. But honestly, there have been dramatic improvements both in surgical technique and critical care, on top of the fact that I think imaging has helped clinicians in terms of dealing with many of the complications of the procedure, and accordingly, perioperative mortality rates are now relatively low, under 1%, although there is still a quite significant rate of complications. It is worth noting that your rate of complication and your rate of mortality are much lower if you undergo the procedure at a major center that does many, many of these procedures every year. Now, when you're talking about a Whipple procedure, there's really two types you should be familiar with. There's the classic Whipple, which entails resecting the pancreatic head, neck, and uncinate process, as well as the duodenum, the gallbladder, the distal bile duct, and the proximal jejunum, and you remove the gastric antrum. And then there's the so-called pylorus preserving procedure, a Whipple procedure, where you resect all of the stuff I talked about earlier, but you retain the gastric antrum and the first portion of the duodenum. In a classic Whipple procedure, you're going to have a gastrojejunectomy, whereas in a pylorus preserving procedure, you're typically going to have a duodenojejunectomy. Now, the pylorus preserving procedure was originally intended to reduce the risk of bile reflux, but there's a lot of data in the literature suggesting that there's really not a lot of difference in terms of patient outcomes when you undergo the classic or the pylorus preserving Whipple. And honestly, at Hopkins, at least from what I've seen, a lot of whether or not you get the classic or the pylorus preserving Whipple is going to be based on your surgeon's preference and their own comfort level. Now, it is worth noting that the criteria for utilizing the Whipple procedure has dramatically expanded over the course of the last decade, right? In the old days, if you had pancreatic cancer and you wanted to get a resection, it essentially meant that you had to have no metastatic disease and no significant vascular involvement. But as we've developed this new category of borderline resectable pancreatic cancers, we found that even patients with relatively significant vascular involvement by tumor are still potentially surgical candidates, and that, at least at Hopkins, has resulted in a dramatic increase in the volume of Whipple procedures that we're performing at our institution. Now, there are a number of innovations that have come with that increasingly performing the Whipple procedure, and that includes laparoscopic Whipples, which we have a few surgeons here at Hopkins who are doing those, as well as relatively complicated vascular reconstruction methods that make those Whipple procedures possible in patients who have tumoral involvement. So SMV and portal vein reconstructions, venous interposition grafts, splenic vein grafts, all of these are used to facilitate the Whipple procedure in patients who have quite significant venous involvement by tumor. Now, as I mentioned before, the classic Whipple procedure is going to give you three anastomoses, right? You're going to have the pancreatic jejunostomy, so the pancreatic remnant and the jejunum. You're going to have a biliary enteric anastomosis, which can be a hepaticojejunostomy or a choledochojejunostomy. And then you're going to have either a gastrojejunostomy in the classic Whipple, so an anastomosis between the stomach and the jejunum, or in a pylorus preserving Whipple procedure where you retain the gastric antrum and the proximal duodenum, you're going to have a duodenojejunostomy. And so those are the three anastomoses that you need to really look at carefully every time you evaluate one of these cases, right? Every case, I find the three anastomoses: hepatico-J, pancreatico-J, and either the gastro-J or the duodenojejunostomy, depending on the type of Whipple procedure the patient has had. Now, I'm a strong believer that anyone who's had a prior Whipple procedure needs to be imaged with dual phase technique. And that means arterial phase imaging, typically at about 30 to 35 seconds after IV contrast, and a venous phase at typically 60 to 70 seconds after IV contrast. Now, I typically avoid giving positive oral contrast in this group of patients unless I'm concerned about a leak at the gastrojejunostomy. And the reason for that is that if you're really looking at the pancreatic remnant and the surgical bed, you don't want contrast pooling in the stomach, potentially resulting in beam hardening artifact or streak artifact that might prevent you from identifying a local recurrence. The only time I give positive oral contrast is in the acute setting where I'm worried about some kind of a leak, usually at the gastrojejunostomy. Now, as I mentioned, the first thing to do anytime you're looking at one of these cases is to find the three anastomoses. The pancreaticojejunostomy tends to be most obvious in the axial plane. And usually you're going to see the anastomosis somewhere near midline or maybe slightly to the right of midline. And immediately adjacent to the anastomosis, you're going to see basically a number of loops of small bowel in the right upper quadrant extending upwards towards the hepaticojejunostomy. Now, it is not at all uncommon to identify this radiodense linear foreign body within the pancreatic duct extending across the anastomosis, as in this case. That's a pancreatic duct stent, which is increasingly being used by surgeons to minimize the risks of a pancreatic leak or a pancreatic fistula. Now, the hepaticojejunostomy tends to be most obvious in the coronal plane, and so I always use my coronal MPRs to identify this particular anastomosis. In rare instances, as in this case, you're going to see a stent traversing the anastomosis, but this is not at all common. And typically, you're going to use gas within the biliary tree, extending from the bile ducts into the jejunum as a way to trace this particular anastomosis. And then finally, the gastrojejunostomy is going to be visible either in the axial or the coronal plane. And typically, it's going to be the easiest of the three anastomoses to identify. In this case, you can nicely see the anastomosis between the stomach and the adjacent jejunum. Now, I think it's important, especially if you're not used to looking at a lot of these cases. In my case, I look at postoperative Whipples pretty much every day, right? We do hundreds of Whipple resections here at Hopkins every year, so I see postoperative Whipple procedures all the time. And over time, it becomes obvious what is normal postoperative change and what's actual pathology. But I work with residents and fellows who haven't seen a lot of these cases, and it can be very easy to mistake normal postoperative stuff from actual pathology. So what are you looking for? What's normal in the acute perioperative setting? Well, in the acute setting, it goes without saying that fluid, fat stranding, and edema surrounding the surgical bed are going to be common. There's almost always going to be induration surrounding the SMA and SMV. So in other words, stranding in density immediately posterior to the SMA and SMV, often quite crescentic in morphology. Usually it's just postoperative change. You're going to often see multiple reactive lymph nodes in the central mesentery, usually subcentimeter, but can rarely be larger. These are not metastatic. These are reactive lymph nodes as a result of the inflammation. Now, in the acute postoperative setting, thickening at the anastomoses is not at all uncommon, right? So you can see thickening of the gastrojejunostomy, and often there may be mild proximal dilatation of the stomach as a result. And you can also see that the pancreatic duct may be dilated as a result of, probably as a result of edema at the pancreatic jejunostomy. Those are common findings, and in most patients, they're just going to resolve over the course of time. Similarly, a little bit of biliary dilatation is not uncommon in the acute setting, again, probably as a result of edema at the hepaticojejunostomy. So in most cases, as long as it's mild, you're just going to follow it over time, but it doesn't necessarily mean that you've got a recurrent tumor or that you've got a stricture at the anastomosis. Now, here's a normal postoperative case, right? None of this is concerning. There's stranding and edema. Notice this induration behind the SMA and the SMV. Notice the presence of the pancreatic duct stent. All of these findings are going to resolve over time. You don't need to worry about a leak. You don't need to worry about the possibility of recurrent tumor. The pancreatic duct stent in some cases can stay in the same place for months at a time, or in other patients can migrate relatively rapidly into the bowel. It doesn't really matter. I just report where it is on in my dictation. Now, in the chronic setting, that tends to be where people get into more trouble, in that they mistake normal findings for tumor recurrence. Now, in most cases, the inflammatory stuff that I talked about earlier should resolve by about 3 to 6 months. So the induration in the surgical bed, the reactive lymphadenopathy, most of that is going to be gone either at their first follow-up or in their second follow-up by about 6 months. But the one finding that can stick around for a long period of time is this crescentic rind of soft tissue immediately posterior to the SMA and SMV. That is a classic location for postoperative fibrosis. I see it in nearly every patient that I look at. And it's the morphology that's going to help you differentiate this from tumor. It's going to be crescentic, linear, not mass-like. If you start seeing rounded soft tissue, nodular soft tissue, well, that's not likely to be fibrosis. You really have to worry more about recurrent tumor at that time. Now, in most cases, the pancreatic duct and the biliary tree, the dilation of the ducts is going to resolve on one of your follow-up studies. But that being said, it is possible that you can have mild pancreatic and biliary ductal dilatation forever, and it doesn't necessarily mean that you have a stricture. Where you do need to worry is if you see severe dilatation or if that dilatation is progressing over time, and in both cases you need to worry about either anastomotic stricture at the hepaticojejunostomy or the pancreaticojejunostomy, or recurrent tumor that's actually obstructing the duct. Now, thickening of the bowel is actually quite common, especially the right upper quadrant jejunum or thickening of the gastrojejunostomy. And in most cases, this isn't pathology, doesn't mean that you have enteritis or ischemia, but it's usually because these patients are increasingly being treated with adjuvant radiation, either before or after their treatment, and these bowel loops end up getting included within the radiation port, and so they can look thickened for long periods of time. And that's not a pathologic finding. And for similar reasons, you can end up with geographic areas of steatosis in the left hepatic lobe as a result of radiation therapy that includes the left hepatic lobe within the radiation port. So now that we know what normal looks like, let's talk about some of the complications that you should be looking for and how exactly you can help guide the treatment of these complications. Now, by far, the most important complication that you need to be cognizant of is pancreatic fistula, which is a kind of fancy surgical term for a pancreatic leak. It represents breakdown either of the pancreatic-jejunal anastomosis or a site of surgical injury in the pancreatic parenchyma, resulting in leakage of amylase-rich pancreatic secretions from the pancreatic duct. Now, classically, this was a clinical diagnosis, right? So they would look at the drain fluid amylase level, and if it was 3 times higher than the serum amylase on the 3rd postoperative day, then the surgeons would say, by definition, this patient has a pancreatic fistula. Now, that is still, to this day, the way in which this diagnosis is made in most patients. But that being said, we are increasingly seeing findings on CT that can help suggest this diagnosis, and in many cases, we can make the diagnosis on a CT scan, and they can confirm the diagnosis looking at the drain fluid amylase levels. Now, this is a critical diagnosis to make. This is the single most important cause of morbidity and mortality after the Whipple procedure. I'm going to talk about a bunch of complications. This is the one you've got to be thinking of. The rate of fistula is somewhere between 6 to 14%, and the mortality rate may be as high as 4% if you have a pancreatic fistula. So this is a critical diagnosis, and I'll tell you, talking with our surgeons, this is the one they're always the most worried about. Now, who gets a pancreatic fistula? Now, some of it has to do with surgical technique, but there are a number of risk factors, including having a relatively small pancreatic duct, soft pancreatic parenchyma, or having lots of intraoperative blood loss. And there's also an association with other complications. So if you have a pancreatic fistula, you're more likely to have sepsis, pancreatitis, form an abscess, hemorrhage, or develop delayed gastric emptying. So this is a big deal, right? If you end up with a pancreatic fistula, the odds are that you run the risk of developing other major complications, and you're much more likely to have a poor clinical outcome. Now, as I mentioned, this is primarily a clinical diagnosis based on your drain amylase levels, but any time in the immediate postoperative setting where you see a focal fluid collection, focal blood, or ectopic gas immediately adjacent to the pancreatic jejunostomy, you have to worry about the possibility of a leak. And especially if you can trace that fluid or gas directly in contiguity with the pancreatic duct or the anastomotic suture line. So here's an example. This is a patient who came to us with a known diagnosis of a pancreatic fistula. They had a drain amylase level of close to 5,000, a serum amylase of 26. So as I mentioned, clinically, you can make the diagnosis of a pancreatic fistula based on the drain amylase alone. But notice that the CT scan is classic for a leak. There's a focal fluid collection immediately adjacent to the pancreatic jejunal anastomosis. There's ectopic gas. We're not seeing the tiny amounts of free fluid adjacent to the pancreatic bed that I said was normal earlier. This is a large amount of fluid, a discrete fluid collection, lots of ectopic gas, all of which are very close to the pancreatic jejunal anastomosis. Notice that the fluid collection is actually directly invaginating into the anastomosis itself. This is clearly a leak, and you can see in the second image that they've put in a surgical drain, or a percutaneous drain. Here's another example. Again, you can see that there is a focal fluid collection directly extending into the pancreatic jejunal anastomosis. If you see that in the immediate postoperative setting, that is a leak until proven otherwise, and you need to call the surgeon and make sure that they have looked at drain amylase levels to confirm the diagnosis. Now, most cases today, if you develop a pancreatic fistula, the patient is going to be treated conservatively. They're going to put in a percutaneous drain to kind of deal with the fluid collection, but the patient typically is not going to go directly to the operating room. The only instance where you might potentially precipitate the patient going back to the OR is if you see signs of massive anastomotic dehiscence. So large free air, large fluid collections, something that makes you suspect that the anastomosis is completely broken down. And typically this is not a clinical dilemma, right? When you have massive anastomotic dehiscence at the pancreatic jejunostomy, these patients are really sick, they're in the ICU, they're on the verge of dying. So this is not usually going to be some kind of a dilemma for the surgeons to deal with. Now, pancreatic jejunal leaks are by far the most common leaks that we deal with in clinical practice, right? Yes, you can rarely end up with leaks at the gastrojejunostomy or at the biliary enteric anastomosis, but honestly, they're pretty rare. Gastrojejunostomy leaks in particular are extraordinarily rare, right? I've only seen, I think, one or two over the last few years, and almost always these are secondary to major technical failures at surgery. And it goes without saying that this is a big deal, almost always associated with major morbidity and mortality. And a gastrojejunostomy leak typically will require them to go back in to do operative intervention. Now, bile leaks or biliary enteric anastomotic leaks are much less common than pancreatic fistula, but certainly much more common than a gastrojejunostomy leak. Again, typically due to technical failure at surgery. You're going to make this diagnosis when you see a focal fluid collection or a large amount of free fluid directly adjacent to the biliary enteric anastomosis. Remember, the location of a fluid collection can be very helpful in terms of figuring out where the patient has a leak. If you see a fluid collection adjacent to the pancreatic jejunostomy, it's most likely a pancreatic fistula or a pancreatic jejunal leak. On the other hand, if you see a fluid collection in the right upper quadrant near the hepatic jejunostomy, you have to worry that it's probably a bile leak from the hepatic jejunostomy. If you're not sure, hepatobiliary scintigraphy or nuclear medicine studies can be very helpful in terms of defining whether the patient truly does have a leak from the biliary enteric anastomosis. Now, pancreatic fistula is the most important complication. I would say the second most important complication that we deal with or see as radiologists is going to be postoperative hemorrhage. Now, if you see enough postoperative Whipple cases, you will see postoperative hemorrhages. And I think a lot of people just aren't aware that this is a major, well-known complication of the Whipple procedure, but it is. And even though it's relatively rare, it does occur in up to about 4% of patients, and when it does occur, it's associated with quite significant mortality rates, perhaps as high as about 40%. Now, postoperative hemorrhage after the Whipple procedure typically is extraluminal, so outside of the bowel, 2/3 of cases, but can be intraluminal as well, so can occur within the gastric remnant or the right upper quadrant small bowel. Now, the initial presence of blood clinically clinically or on a CT scan is termed a sentinel bleed. So the first time you bleed, you have to be urgently worked up, as that bleeding implies that you either have A, structural vascular abnormality, or B, an anastomotic dehiscence. But either way, that bleed really heralds the fact that you have something really bad going on and you really need to be worked up to figure out what it is. Now, postoperative hemorrhage can be broadly defined broadly divided into two types. There is early postoperative hemorrhage that occurs in the first 24 hours after surgery, and it's almost always going to be bleeding from the GDA stump, typically as a result of inadequate ligation during surgery. On the other hand, late postoperative hemorrhage tends to occur a few days later, usually after 5 days, and by this point you're dealing with a real structural abnormality of the vasculature. So it could be an erosion, a pseudoaneurysm, but again, it's typically going to be from the GDA stump, either active erosion with extravasation or a pseudoaneurysm. Now, these late postoperative bleeds have a very high association with anastomotic breakdown, and again, it goes without saying, associated with very high morbidity and mortality. So here's a patient immediately after the Whipple procedure. You can see that there's a big bleed. Notice the presence of active extravasation. This patient actually ended up going directly to angio for embolization. Here's another example. This patient is about, I think, 6 days after surgery. You can see there's a big hematoma surrounding the pancreatic bed. Now, as I mentioned before, when you have late post-Whipple bleeds, there tends to be an underlying vascular abnormality, a structural abnormality. And in this case, you can see that there's a large pseudoaneurysm of the splenic artery. Now, this is one of the reasons why I am a strong believer you've got to get arterial phase images routinely in patients who've had a prior Whipple. I'm going to promise you, will miss small pseudoaneurysms if you're just dealing with a venous phase. Now, in most cases, the arterial phase may not help you, but in that 1 in 100 case where you're dealing with a large bleed and you want to find that subtle pseudoaneurysm or active extravasation, you will be thankful that you're routinely acquiring the arterial phase images as part of your protocol. Here's another example. This patient had a large bleed adjacent to the surgical bed a few days after the Whipple procedure, and noticed that there's a pseudoaneurysm on the angio arising from the inferior pancreatic duodenal artery. Here's another example. Again, a large bleed, active extravasation from the GDA stump. You can see this layering, active extravasation. This patient is, I think, immediately post-op, and so, as you'd expect, it's usually going to represent bleeding from the GDA stump. Now, as I mentioned earlier, 2/3 of cases are intraluminal, but I've seen plenty of examples where patients have postoperative Whipple bleeds where it's intraluminal, classically either the gastric remnant or the right upper quadrant small bowel. Here's an example. This patient was having massive GI bleeding after surgery, and you can see that there's lots of blood distending these right upper quadrant jejunal loops, and ostensibly this bleeding has something to do with problems in the vasculature related to the way in which the surgery was done. Now, those are probably the two most important complications in the acute setting. A common complication that I think we tend to miss, or at least underdiagnose on CT, is postoperative pancreatitis. And this is actually quite a difficult diagnosis because how do you know if you're dealing with pancreatitis or alternatively just postoperative inflammatory change? So even though this is pretty common, probably in about 1/3 of all cases, I'd say that we very rarely ever make this diagnosis because we just write it off as being postoperative. That being said, if you see a disproportionate amount of inflammation around the pancreatic remnant, rather than diffusely in the surgical bed, and especially when you see a disproportionate amount of fluid tracking from the pancreas along the pararenal spaces, you should at least think about the possibility of postoperative pancreatitis. Now, another major complication that you have to be looking for when you're dealing with these postoperative cases is portomesenteric venous thrombosis. And this has actually become more and more of a problem as surgeons are doing all kinds of complex venous reconstructions to treat patients who at one point were considered unresectable because of tumoral involvement. It goes without saying that you start doing more venous interposition grafts, jump grafts, so on and so forth, that your risk of venous thrombosis goes up considerably. So if you look at the traditional literature, it says that 17% of patients with a Whipple procedure develop venous thrombosis, and I'd say that's probably an underestimate, given that we've only in the last few years started seeing these more and more complex venous reconstructions. Now, in most cases, patients with portomesenteric venous thrombosis will be treated with systemic anticoagulation, but in the immediate postoperative setting, surgical thrombectomy is theoretically an option. Now, this is a diagnosis that you really shouldn't miss, provided that you take the time to actually look at the vasculature in every postoperative case. This has to be a part of your standard search algorithm. Every time I look at a post-Whipple, I'm looking at the portal vein, looking at the confluence, looking at the SMV. And as long as you look at those vessels, you're not going to miss this diagnosis. This is pretty obvious, right? Portal vein thrombosis, not a difficult diagnosis, provided that you actually take the time to look at the portal vein. Similarly, SMV thrombosis, not difficult. Take the time to look at the vessel, use the coronal reconstructions when you're looking at the SMV, and you won't miss this diagnosis. Now, a relatively rare complication is hepatic infarction, but this is something that you'll see every once in a while. Usually in patients who not only have some kind of surgical injury to the vessel, but also an underlying abnormality in the mesenteric arterial vasculature. And the reason for that is because the liver has a dual blood supply via the hepatic artery and the portal vein, just having a single abnormality or a single vessel involved usually isn't enough to give you an infarct. So typically you have to have an underlying abnormality in the arterial vasculature and then something that pushes you over the edge, whether it's an arterial thrombosis or portal venous clot, so on and so forth. So always these patients will have, severe atherosclerotic disease, median arcuate ligament syndrome, FMD, vasculitis, so on and so forth. And then the surgery and some complication associated with the surgery typically pushes them over the top. Now, I'd say the most common is some kind of an injury to either the hepatic artery or the celiac artery during surgical resection or dissection, and that tends to be especially problematic when you have a larger tumor that's surrounding multiple vessels. And as you can imagine, as we're resecting more and more tumors that do have underlying vascular involvement, this is increasingly common. Now, one situation where I've seen this happen, actually the most common situation where I've seen this happen, is where the presence of a replaced or accessory right hepatic artery wasn't noted on the preoperative scan, wasn't noted at surgery, it was inadvertently sacrificed during the procedure, and the patient ends up with a right hepatic lobe infarct. Now, this is what you don't want happening, right? This patient had a large right hepatic lobe infarct. They actually had, I believe, a replaced right hepatic artery that wasn't noted at surgery or on preoperative imaging. And that infarct has gone on to develop into a biloma. The biloma got superinfected, and now you've got a big infected infarct or infected liver abscess. Now, what's the most common complication in the postoperative setting? And it's actually something that we don't think of as a big deal, and honestly, we don't tend to make this diagnosis a lot on imaging, but it's quite common, and that's delayed gastric emptying, which affects probably about 50% of patients who have undergone a Whipple procedure. No one knows why it happens, right? It may be because of some kind of localized disturbance of the autonomic innervation of the stomach near the operative bed, but that's just a guess. No one really has a good idea why it happens, but we do know that it tends to be more common in patients who have other postoperative complications. Abscess, fistula, intraoperative blood loss, and so on and so forth. Now, in most cases, it's going to be a tough diagnosis to make on a CT scan, and honestly, it's primarily a clinical diagnosis. The surgeons define this as a patient who has prolonged need for a nasogastric tube. So basically, they take the NG tube out, the patient can't tolerate it, they have to put the NG tube back down. That is quote-unquote delayed gastric emptying. But there are some features on a CT scan that can help you at least suggest a diagnosis. So if you see a massively distended stomach with lots of retained ingested material, food particulate material, then you're probably dealing with a patient who has delayed gastric emptying. Now, honestly, the diagnosis is usually going to be obvious to the surgeons clinically. CT isn't really critical for this diagnosis, but it's, I think, something good for the radiologist to understand as to why they're seeing a distended stomach after the Whipple. Now, in most cases, it has to do with the underlying autonomic innervation, but in the immediate postoperative period, you can end up with a dilated stomach as a result of edema and thickening at the gastrojejunal anastomosis, as in this case. But in most instances where you have discrete edema at the anastomosis resulting in some form of partial obstruction, that should resolve over time as the edema goes away. Now, in the chronic setting, one of the complications you have to think about is anastomotic stricture, and this is actually a pretty common delayed complication, both at the hepaticojejunostomy and to a lesser extent at the pancreaticojejunostomy. Now, the timelines or the time frames in which you're going to be looking for these anastomotic strictures is, I think, important to know. Pancreatic and jejunal strictures tend to occur pretty early, right? And so the median time to diagnosis is 3 months. So this is something you're going to see on their immediate postoperative follow-up or maybe a couple of follow-ups down the line. On the other hand, hepaticojejunostomy strictures take a little longer to develop, 18 months, 2 years. So this is something you're going to be looking at years down the line potentially, and so not something you're going to see in the immediate first follow-up or second follow-up. Now the key when you're looking for anastomotic strictures is to pay careful attention to the size of both the pancreatic and bile ducts. Pancreatic duct and the bile ducts. So in every study, this is something that goes into my dictation in the body of the report. I talk about whether the pancreatic duct is stable in size. Is it large? If so, has it changed? Same thing with the biliary tree. Is there new or increasing biliary ductal dilatation? Now, if I see a change in size of either the biliary tree or the pancreatic duct, the first thing I'm going to look for is the presence of a new occult obstructing tumor, right? That's the thing you don't want to miss. You don't want to miss the fact that their pancreatic duct is dilated because they've developed recurrent tumor involving the anastomosis. But if you don't see tumor, then most likely you're dealing with a benign stricture, and that's something that can be in most instances treated non-operatively. And nowadays, patients are typically going to be treated with balloon dilatation. Now here's an example where I think it'd be very easy to just say, well, the patient has a dilated pancreatic duct, probably have a stricture, right? This is actually new. So the patient had a scan, I think 3 months prior, which looked normal, and now they've got a moderately dilated pancreatic duct. But notice that this pancreatic duct, even though dilated, does not extend all the way to the pancreatic or jejunal anastomosis. It actually stops proximal to the anastomosis, and if you look carefully, especially in the image in the bottom right, there's this subtle nodular focus of hypodensity. Remember what I said earlier. Anytime you see an increased size of the pancreatic duct or the common bile or the biliary tree, you need to rule out the presence of an occult obstructing tumor. And in this case, there was a subtle subcentimeter obstructing lesion at the pancreatic or jejunostomy, and that was confirmed based on endoscopic ultrasound. So in summary, hopefully I've given you again a sense for why proper CT technique is critical. Now I will admit, in most cases, as long as you have good venous phase images, you're going to be able to identify most complications. But as I've shown you, postoperative bleeding is one of the most feared complications of the Whipple procedure, and if you don't have arterial phase imaging, you potentially could miss active extravasation or a structural vascular anomaly, such as a pseudoaneurysm, that potentially could cause significant morbidity and mortality. Second, understand what's normal. I'd say some of the biggest mistakes I've seen after a Whipple procedure in terms of interpretation have been when people have confused normal findings for pathology or vice versa. They saw something that was clearly abnormal, but they figured, well, it probably is just normal post-op. If you understand what normal looks like, you're going to be in a much better position to identify appropriately those complications that may be life-threatening. Finally, I really believe in taking an algorithmic approach when I'm looking at these post-operative cases. I look at every one of these cases the same way every single time. I look at each of the anastomoses, and then I look for all of the complications that I talked about earlier. Provided that you look at the anatomy adequately and you look carefully for the complications I talked about, you're not going to miss anything major that could lead to significant patient morbidity and mortality. So that's all I have. Thanks again. I'll see you guys later.